Good afternoon, everyone. I'd like to begin by thanking Amol and my chairperson, Dr. Vivedi, and everyone else on the stage. It's always good to come back to India. And I was struck by the three flags on the stage. And I think I can pledge allegiance to two of them anyway. So with that, I'll get started on my lecture. So this is a brief outline of my talk. Good afternoon, everyone. I'll start with I'd like to begin by thanking electronic endoscopy, Amol, the detection exchange and chairperson, Dr. Vivedi, and then come methods of electronic endoscopy. And I was struck by three flags on the stage. And I think I can pledge allegiance to two of them anyway. So and finally that I'll get started on the lecture. So this is a brief outline of my talk. I'll start with I'd like to begin by thanking Amol, the detection exchange and chairperson, Dr. Vivedi, and then come methods of electronic endoscopy. And I was struck by three flags on the stage. And I think I can pledge allegiance to two of them anyway. So finally that I'll get started on the lecture. So this is a brief outline of talk. I'll start with I'd like to begin by thanking Amol, the detection exchange and chairperson, Dr. Vivedi, and then come methods of electronic endoscopy. And I was struck by three flags on the stage. And I think I can pledge allegiance to two of them anyway. So finally that I'll get started on the lecture. So this is a brief outline of talk. I'll start with I'd like to begin by thanking Amol, the detection exchange and chairperson, Dr. Vivedi, and then come methods of electronic endoscopy. I was struck by three flags on the stage. And I think I can pledge allegiance to two of them anyway. So finally that I'll get started on the lecture. So this is a brief outline of talk. I'll start with I'd like to begin by thanking Amol, the detection exchange and chairperson, Dr. Vivedi, and then come methods of electronic endoscopy. I was struck by three flags on the stage. And I think I can pledge allegiance to two of them anyway. So finally that I'll get started on the lecture. So this is a brief outline of talk. I'll start with I'd like to begin by thanking Amol, the detection exchange and chairperson, Dr. Vivedi, and then come methods of electronic endoscopy. I was struck by three flags on the stage. And I think I can pledge allegiance to two of them anyway. So finally that I'll get started on the lecture. So this is a brief outline of talk. I'll start with I'd like to begin by thanking Amol, the detection exchange and chairperson, Dr. Vivedi, and then come methods of electronic endoscopy. I was struck by three flags on the stage. And I think I can pledge allegiance to two of them anyway. So finally that I'll get started on the lecture. So this is a brief outline of talk. I'll start with I'd like to begin by thanking Amol, the detection exchange and chairperson, Dr. Vivedi, and then come methods of electronic endoscopy. I was struck by three flags on the stage. And I think I can pledge allegiance to two of them anyway. So finally that I'll get started on the lecture. So this is a brief outline of talk. I'll start with I'd like to begin by thanking Amol, the detection exchange and chairperson, Dr. Vivedi, and then come methods
So association between colorectal link was confirmed, and what was suggested was get rid of the colon. The surgeons So association between colorectal link was confirmed, and what was suggested was get rid of the colon. The surgeons interestingly, 43 to 58% risk of synchronous colorectal. Why do we need? Screen aim number 2, early detection and treatment. So association between colorectal. What is the risk? And the next question, which I'm always between colorectal links was confirmed, and what was suggested was get rid of links was confirmed, and what was suggested was get rid of links was confirmed, and what was suggested was get rid of bowel disease than the general population. The risk of CRC, 90 to 58% risk of synchronous colorectal. Why do we need? Screen aim number 2, early detection and treatment. Number 2, early detection and treatment. So association between colorectal. What is the risk? And the next question, which I'm always between colorectal links was confirmed, and what was suggested was get rid of links was confirmed, and what was suggested was get rid of links was confirmed, and what was suggested was get rid of bowel disease than the general population. The risk of CRC, 90 to 58% risk of synchronous colorectal. Why do we need? Screen aim number 2, early detection and treatment. Number 2, early detection and treatment. So association between what is the risk? And the next question, which I'm always between links was confirmed, and what was suggested was get rid of links was confirmed, and what was suggested was get rid of links was confirmed, and what was suggested was get rid of bowel disease than the general population. The risk of CRC, 50 to 58% risk of synchronous colorectal. Why do we need screening? Number 2, early detection and treatment. Number 2, early detection and treatment. So association with what is the risk? Now the next question which I want is right mix was confirmed. Action on dysplasias assessments. Right mix was confirmed. Action on dysplasias assessments. Right mix was confirmed. Action on dysplasias assessments. Disease than the general population. The risk of CRC, 50 to 58% risk of synchronous colorectal. Eliminate screening. Number 2, early detection and treatment. Number 2, early detection and treatment. What is the risk? Now the next question which I want is than the population. The risk of CRC, 58% risk of synchronous colorectal. Number 2, early detection and Number 2, early detection and what is the risk? The next question is on what is the risk? The risk of CRC, 58% risk of synchronous
At 100 patients, like what will be the percentage of carcinoid in the colon?
An adenoma and a carcinoid, they are totally different colonoscopy. And you start doing an NBI, they are absolutely different. Adenoma has its own pattern which guys told us. While in carcinoid, normal colon.
I would like to know in your practice, like if you see 100 patients with polypoid lesions, how many would be carcinoid?
I've taken only 3 rectal carcinoids up to now, and all of them I knew that they are not adenomas. They were more something else than adenomas.
Thank you, Delay. Matthew, you had a question, I believe.
In all patients, yes.
So chromoglobin in all patients.
In fact, even you can get away without it in type 1. You don't do chromoglobin is fine, but you have to do gastric level in gastric carcinoids. It's absolutely mandatory. Like those small carcinoids we see on endoscopy, I don't do anything. I don't do even chromoglobin. I just let them go.
I don't
do it. I always see whether this patient has various symptoms or not. But I don't do, this is a standard recommendation, I don't do it. I always do gastric, that is absolutely mandatory. Even if I see small things, I know they are type 1, but I just confirm them by doing gastric.
Thank you, wonderful. Big round of applause, please. Now we have the last lecture before we move on to the live sessions. May I invite Dr. Matthew Philip. He will be telling us about electrosurgical for EMR, ESD and third phase endoscopy. Dr. Matthew's lecture should be tomorrow. So even the computers have compatibility problems, not only for humans.
Thank you, Chairperson, for the kind words, and I would like to thank the audience for giving me this opportunity. I'm really sorry, my throat is quite bad. Just recovering from a respiratory infection, and the topic is given to me handled by technician. I never ever look at that, and if there's any doubt, actually I just correct it. So anyway, I just tell, and I'll be very brief, and I'll go very superficially. Thank you, Chairperson, for the kind words, and I would like to thank Opportunities, so I'm really sorry, my bad is quite bad. Many times recovering from and the problem is actually handled by technician. I never that. And any doubt the industry corrected. So anyway, I will just tell, and I'll be very brief and go very superficially. Some chairpersons and persons for kind words, and I would like to thank opportunities, so I'm really sorry, my bad is quite bad. Many times recovering from and the problem is actually handled by technician. I never that. And any doubt the industry corrected. Just tell, and I'll be very brief and go very superficially. Some chairpersons and persons for kind words, and I would like to thank opportunities, so I'm really sorry, my bad is quite bad. Many times recovering from and the problem is actually handled by technician. I never that. And any doubt the industry corrected. Just tell, and I'll be very brief and go very superficially. Some chairpersons and persons kind words, and I would like to thank opportunities, so I'm really sorry, my bad is quite bad. Many times recovering from and the problem is actually handled by technician. I never that. And just tell, and I'll be very brief and go very superficially. Some chairpersons and persons kind words, and I would like to thank opportunities, so I'm really sorry, my bad is quite bad. Many times recovering from and the problem is actually handled by technician. I never that. And Blend picture. You get something in between this. You get a tissue is incised as well as you get a hemostasis also. This is the principle of endocut which will come to it. And this is also important. Duty cycle is a terminology which is very commonly used in electrosurgical units, and this is especially useful for dry cut, soft, swift cut, and force cut, which I'll come to it later. And what is endocut? What does it mean? So actually, initially you get an incision, then you get an interval of coagulation, then incision, coagulation, and that is that cycle. And as it goes on, actually the current also increases and your effect also increases. So the initial machine of airway that series, it also had endocut, but the new machine has some other modalities, endocut I and endocut Q. So what does it differ and how does it differ? This is just to show you that there is something called a peak voltage that is quite important, and it is fixed. And it has got three parameters by which you can adjust the cut effect or coagulation. One is the effect, what you see, that is hemostatic effect, that is the coagulation, and speed of incision or the cut interval. And you can actually set all these in the new machine. So what is endocut? That is fractionated cutting motor. This is basically used for papillotomies, and also when you use needles or wires, suture effect, etc. And also how does it help? How does it minimizes the polypectomy, rapid polypectomy effect, or zipper affecting sphincterotomy. What is endocut? It is again fractionates the cutting process into a controlled and a coagulation interval. So you can actually adjust it if you want. You can adjust the effect. You can adjust the duration. All these can be adjusted. And this is quite useful for endoscopy, polypectomy, as well as for EMR, ESD. Here actually the coagulation is slightly more because you want hemostasis also. Just to show you that, again, endocut I is for papillotomies, and endocut Q is for other two. There is something called expert mode. What is that? Expert mode. This is actually just like your mobile. You can actually keep a password or a key where you can adjust your tune. If many people are using. So you can actually use your tune, and when you switch off the machine, you can use something called an expert mode. And coming to dry cut. What is dry cut? It's actually cuts using modulated current. Forms with pronounced hemostasis. And this is used mainly for ESD, poem, etc. if you want. And when you come to coagulation, you know there are three different terminologies. One is a soft coagulation, and it's a forced coagulation, and it's a swift coagulation. What does it mean? You just do three aspects of it. One is the depth effect, coagulation, speed, and then this dissection property. And you know that swift coag has got depth is less, but you have got other two higher. When you get a soft coagulation, the depth is slightly more, the other two are less. So like that, forced coagulation has got something in between. So these are recommended settings. Please note that there is no standard recommended settings for all people. Every center has their own technique, their own settings. But no, what I'll come as a last slide. I'll show what is the recommendation done by the airway company for that. So what are the complications of electrosurgery? You know there are so many. Especially if you are not using it properly, if your grounding part is not correct, and the patient is not being looked after or being connected correctly, you can have complications. Especially even the ECG pad can produce bad. The grounding pad can produce bad. And if it is in a pregnant patient, fetus can get affected. And there are so many other complications. There are so many patient with a cardiac pacemaker, patient has got a cardiac implanted cardiac defibrillator. All these are very important. Rarely power explosions reported. So you just So you just how to use the patient plate. How to use the patient you have to keep it as near as possible. It is said that 15 centimeter away from the side what we use, and it should not be directly over any bones. And not on any damaged skin. Suppose you have got a wound, never use it. If there is any bleeding area, never use it. And not in areas where fluid collects also. Especially when there is patient is wet and all, you should be very careful about that. And do not allow any cables or cable connectors to create pressure points in that area. And do not direct the path of current across the implants, especially bones or other cardiac implants, etc. And you should keep this electrode in these areas. They are the best areas to apply. As you have to keep it as near as possible. It is said that 15 centimeters, and when a pregnant female, never put on the lower areas. And this is actually a patient has an implant, and you should not keep over that area, because if current passes through that, there is a possibility of damage to the implant there. So you should keep it on the other side of that. So you should know about the background of the patient quite well. In cardiac patient, the observation is that observe instructions for use in what implant they have used, and always contact the cardiologist and the manufacturer and of the pacemaker, and preferably use.
That is the bank you own, Cosmos Bank. There is a bank behind Cosmos Bank. That is owned by you.
No. That's just the calendar, not owned by me. I don't have enough money to open an account there. In fact, all the money is gone for the conference. So, he is starting 3 theaters simultaneously, and we have Dr. Naresh Barrett here to demonstrate, evaluate the case with NBI, and then simultaneously we will have Mangeshkar, Dr. Amit Mahadev starting tunneling endoscopic resection in the third theatre. And then we'll be running these theatres simultaneously, and we'll be switching from one theatre to another. And we have about 9 procedures lined up for today afternoon session, and another 12 for tomorrow morning.
Can somebody switch off the microphone in the other theatre, please? We're getting disturbance from there. Okay, thank you.
So, can we have the first slide, please, and maybe Naresh or Ravindra give the patient history and also the section of Naresh and Prasad. And then we'll be running these theatres simultaneously.
Hello, can you hear me, sir?
Go ahead, please.
This is a 62-year male who presented to us with bleeding PR and complaint of generalized weakness. On evaluation, he had iron deficiency anemia. We transfused him with 2 units of blood, and then colonoscopy was done. Colonoscopy revealed a large rectal villus lesion starting just proximal to dentate line and was extending into rectum. It was circumferentially involving rectum. The plan is to do NBI and further discussion.
Did you biopsy the biopsy lesion?
No, biopsy was not done, sir. My over to Dr. Mangeshkar.
What was your impression? That is splitting tumor or something? The microphone in the other
Lateral splitting tumor.
We're getting disturbance from there. Okay, thank you.
So,
With me. Naresh, we can't hear you, Naresh. Can you use the microphone, please? It's not on?
should be on.
No, Naresh, we can't hear Naresh. We can hear Prasad. Naresh, we can't hear you.
Are you able to get the endoscopy view, SP?
Yeah, no, we're not getting the endoscopy. We can see you, but not the endoscopy view.
Can someone handle that?
We can see the endoscopy view, but we can't see you now.
Okay, decide whether you want to see the
Okay.
colon or you want to see me.
Okay, now we can see you. We have the picture now.
All right, I think what you need is a big view of the...
Prasad, can you could be closer to his mouth, please?
Yeah. All right, so what I could do is, I just did a rectal examination and I could feel a soft mass there right at just beyond the anal verge. So there is a polypoidal lesion that I could feel rectally on my rectal examination. So I have gone in with a scope and I have gone in with a high definition gastroscope, which is easier to sort of manipulate and retrovert and things like that. Yeah, can we have the first slide, please, and maybe Naresh or Ravindra give the patient history and also the section of Naresh and Prasad. And then we'll be running these theatres simultaneously.
Hello, can you hear me, sir?
Go ahead, please. Go. Nagesh, you plan to do a full-length colonoscopy or just a limited
We have done a
colonoscopy?
full-length colonoscopy, so I'm just going to interrogate this lesion that is now coming to view.
Okay.
You see this is a
Oh, it looks more.
pretty big lesion. There goes, let's see,
It's more polyposis than a lateral spreading tumor.
correct? And what is a lateral spreading tumor? That's, I think, what the audience needs to know about. I think the first thing that we see about a polyp is, one is the Paris grading, and this definitely is a flat lesion which is going across. So this would be a 1S or a combination 1S and
Probably a 1S, 1P kind of a lesion. I think it has both components.
maybe it's a 2A component should be included in All right, the next,
So Saichiro, why do you say 2A?
generally speaking, for some we
SP, SP,
see the 2A component in such kind
SP, Dr. SP,
we should
Mr.
especially in
A question. They may not be able to hear. See, when you actually want to do an NBI in a rectal lesion, distal rectal lesion, it is preferable to avoid a rectal examination because it produces injury, trauma, so actually the picture will change.
So now is the natural
What we never do a very rough examination. We do a very soft, it's not like a surgical or a urologist who does a rectal examination. We just, anyway, we are going to lubricate, so we do a rectal examination. You don't have to do it very roughly, appreciate that it causes trauma. But remember, it's very easy to use a rectal lesion unless you do a rectal examination. So the point is that you just go to do a colonoscopy.
Somebody switch off they're getting sounds on the second filter, please. Somebody switch off the microphone there.
You are seeing a lot of mucin there. You think it's a villus adenoma?
Yes, there is some mucin, there is some.
We can hardly hear, we can't hear you, Nagesh.
Hear it for a There is some mucus there, definitely, no doubt about it. And if you look. Screen come
That's it.
Here on white light, you can appreciate this.
Anmol, can we switch off the microphone, second theater, please? Second theater? Yeah, by the way, they're having a good time over there.
Can you see these front-like structures?
This is 62-year male who
Yes, we can see.
was with bleeding PR and a complaint of generalized weakness.
And let us characterize.
Nagesh, but there's too much of buck over there.
Decent view. What is your specialty? What classification you follow? Or Sino, what do you do?
Kudo is better, and right now we had the lecture that Kudo is the best. And
So what do you use for this? You think this is type 1, 2, 3, 4, 5? Dr. Sichara
in general prostration, type 2A in general prostration, and type 2 in nice prostration. So can you
yes, you can hear you now.
see, I'll just show you the technique of using the ear focus. Is what you do is with NBI you go as close as you can, and when it gets blurred, can I
Show Dr. Nagesh's hands. He has to use the buttons over there. Can you show the hand, focus the hands, please? Yes. We all know he's very handsome.
No, just
Can you focus the hands, please?
eyes up top.
See the button over there.
Yeah, so now you can get very good views of the vessels there and the surface pattern. So you can actually see
That's button.
if you can see the corner of the screen, it says NBI near focus. So that's when you know that the near focus is engaged. I'm just going to turn it off. And now you can see there's no more near focus. I'm going to engage it again. So the technique is to go close and then put on the focus so that you can get best image or your screen to appreciate. And it's important that you look at all the aspects of a polyp, not just one, because there's a large polyp, there may be different changes occurring at different places. Some mild surface So Naresh, one of the things that we always consider is when you look at any of these large polyps, you look carefully for lesions, for characteristics that might reflect an invasive cancer. So if you want to this part looks a bit different. I'm sorry? This part of the polyp looks, the tumor looks a bit different. Yeah, so that's what I wanted Naresh to comment on, as to what are the characteristics he would be looking for which might suggest an invasive cancer.
See, what is most important is if you find surface ulceration or a nodule or nodule is ulcerated.
Naresh, we can hardly hear you. I'm sorry. If you see a nodule or ulceration or a combination of nodule with ulceration, those are fairly features that suggest that there may be an element of cancer or deep invasion. There's a paper that's come from your institution, Mr. Shivanand, Dr. Matsuda's paper on on LSTs and high rate features. Everything knows are these regions? Yeah. We can't hear you again. You have to use a handheld microphone. Yeah, sorry, I thought his new microphone is working. Okay, that's fine. No, it's not working.
Now this looks like a villous growth here. It looks like a granular LST
of a flat polyp, which is more than 10 millimeters, is thought to be a lateral spread tumor
by Professor Kudo. And there you have a granular type and a non-granular type. The granular type has less deep invasion and hence less nodal metastasis, while a non-granular, even if you find that it lifts, can have deep invasion or metastasis. So you'd be a little cautious when you have a non-granular LST. Dr. Bhatt, Dr. Vikram here. Can you hear me? Dr. Bhatia? Yes, so would you say that a villous adenoma in this case, which it is likely is synonymous with a LST? Yes. Yes, if it's on the flatter side, yes, definitely yes. Depending on the size? Yeah. Yes, more than 10 millimeters. But then, would you classify this as a LST? I would. Laterally spreading to, we have lost your audio, sir. I would classify it as an LST. Session, if you have any... Session agrees that you call it an LST as well. And in such a villous surface lesion, how do you classify the lesion as granular versus non-granular for us? It is, see, granular when it looks rough. And you can see this kind of front that I showed you. It looks soft. Yes, but that's the usual surface pattern of a villous adenoma. It always looks to have a villous frondy surface, if I might. Correct. So, would you ever expect, I mean, all villous adenomas by that means would be a granular LST when once they are larger? Most at least. Sorry.
Vikram, I think this is Prasad here. I think you have a good point. You have a good point in the sense that this to me looks more like a villous adenoma than a laterally spreading tumor. That typically is sort of more flatter, and it's sort of running over the entire mucosa, the mucosal surface, and maybe over folds. So this is more a villous frond-like appearing adenoma to me.
There is a question from the audience, sir. Dr. Manish feels that there is one S and not a LS, lateral spreading tumor. 0-1S. Dr. Manish feels this is a 0-1S lesion.
Here you see the flat elevated component whose just near side whose a region. So I think so this region has some flat component, this area. So I think so this macroscopic appearance should be considered as type 2 1S plus 2A LSTG. So this region has a granular surface, lobular surface, so I think it is LSTG.
So I think the important thing is here that you need to assess is how close what is the base?
Does it have a very wide base, which I think it has. It is certainly not circumferential, but it's got a wide base, and it's close to the as far as resection is concerned. Can you show us the base, please? Yeah, I'll try and show you that. In the rectum, sir, would you use a cap to evaluate such lesions, or you do away with the caps? Cap is basically a trauma and bleeding. Cap analysis is not that important. If you're using the zoom scope in Japan, they would like to use the cap, but the dual focus, I don't think the cap is really needed. I'm sorry, because of the audio we missed most of what you said. If someone can...
So I think what he said was that if you are using a dual focus, he does not think that a cap is necessary. If you are doing magnification endoscopy, then he thinks a cap is necessary.
But in dual focus also we are basically magnifying with the near focus. Near focus we magnify.
So I'm not sure there's a lot of magnification. It's really you are going closer to the mucosa and you're engaging narrowband imaging.
For near focus, the focal length is 3 to 7 mm. That's why you don't need a cap for 190. But for magnifying, the focal length is 2 to 3 mm. So you require that distance. That's the difference why you require a cap with magnification, not with the 190 system.
I think the reason to have the cap is more than just the focal length. It does help you fix the mucosa.
Yes, that's important.
It does help
the stability when you use the cap.
Exactly. I think it's more for stability and exposing the lesion and fixing the lesion.
Naresh, we can't hear you again. Sometimes you make at the base of the polyp. Yes, we can, sir. We can. I don't think it's very clear, but we can. The other point about using a cap is you tend to traumatize. And when you traumatize the mucosa, it starts bleeding, especially with these tumors, then it's very difficult to further continue the examination. Yes, but coming to the same question, once we are at the near focus, doesn't the presence of a cap help you stabilize it at the near focus? Actually, not. When you're using a zoom endoscope, if you look at Japanese literature, they're also very clear that when you're using a zoom endoscope, which doesn't have a dual focus, then a cap certainly helps. But if you're not using a zoom endoscope and you're using a dual focus mechanism, then a cap perhaps is not that essential, at least for interrogation. So Naresh, in this case, how does the NBI or the query pattern after endoscopy alter the management? Now, see, in this large lesion, here a white light endoscopy, the things are pretty obvious. If the problem or the issues really come when you have a small lesion, you want to differentiate between a hyperplastic and an adenomatous lesion. Two is when you suspect that there is deep invasion or not. So for practical purposes, what they use is the NICE classification. It sort of tells you whether you need to resect or leave it alone, or whether you should send it for surgery. In this patient, it's not that essential, but basically shows you. Can you see this?
So that's the part which I think looks more like an LST.
Can you just put this?
So I think this is a combination of a villous adenoma and an LST. I think this is an excellent demonstration of the LST part of the tumor. So I think it's a mixed tumor.
Right. So what is the management now? Management is for Sesharo to deal with it tomorrow morning. We'll cook it till tomorrow morning.
Okay, I have a comment. So can you hear me? So, given the macroscopic type and the size of the tumor, even though we estimate the depth of engagement and SM's right, sometimes we face expected deep submucosal engagement. The submucosal deep engagement rate was about 15%. So, we never perform piecemeal resection for this region. Unblock resection was essential. So, tomorrow, I'd like to perform ESD for this finished rectal tumor. Thank you.
The other point that I wanted to emphasize is when you have a non-granular lesion, sometimes it's easy to lift
but we can leave behind the tumor. That's what Seshar also mentioned. So you can get a lifting sign which is positive, but you may leave residual tumor. So ESD is the way to go. But if it is a granular, purely granular, then you may get away with a piecemeal resection or piecemeal EMR.
So, you are done, Naresh?
Yeah, we are done.
Thank you very much. A big round of applause for Naresh and his team over there. For the audience, tea and coffee has been served by the room. You can take off time and have a cup of coffee. Yes, you can hear you.
Dr. Mohan Kashyap is ready with the patient of Acalasia for flow.
Okay.
Mahesh or Ravindra will give you the history of this patient. I think you already have it on the screen.
You don't see them.
Hello? Yes. What? Yeah, this was a 30-year female, 38-year female who presented with history of retrosternal burning pain since past 2 years and occasional dysphagia to solids and liquid. She was treated as GERD, and then when gastroscopy was done, liquid residue with resistance at LES was found. We did manometry. Manometry revealed type 2 Acalasia cardia, and barium swallow was typical of Acalasia cardia. So plan is to do POEM in this case.
What type of Acalasia is this? Type 1,
Type 2 Acalasia.
Type 2, typical. Okay.
So over to Dr. Moin. Okay.
We don't see you, now we can see you. Okay.
And can you?
Hi, good evening, how are you?
Hi. Do you see the endoscopy image?
No, now we are seeing that. No, we lost it again. We can see it now. But
okay, perfect. And I'll be with my good friend Mohan here. You know, Mohan and Mohan. So we're going to be a little confused here, but we'll get the job done. So this is a patient with type 2 Acalasia.
How can we classify M1 and M2?
Okay, we're going to proceed with business here. I think Amal has a lot of cases for you, so we're not going to waste any time. We're going to proceed right away. So we're going to look for the GE junction here. I'm coming back from the stomach. And I'll tell you exactly what we are using in a minute, what scope, what cap. So here the GE junction is at 38 centimeter. So I can tell you the standard is 6 centimeter esophageal myotomy and 2 centimeter gastric myotomy. So 6 plus 2. What I do is 7 plus 3, so 10 centimeter total length of myotomy for ease of measurement. And also just plus minus 1, you know, because sometimes we have error in measurement. So if the G junction is at 38, the end of tunnel is going to be at 41. We're going to do a 10 centimeter myotomy, which means my myotomy is going to start at 31. And the incision will start 3 centimeters prior to that. So that will be around 38. Sorry, 28. So we don't start the myotomy exactly where we do the incision. We started 2-3 centimeter distal because that part will serve as a flap. In this patient, we're doing anterior myotomy. It's not, you can either choose anterior or posterior. I'm comfortable with both, but I'm going to do anterior. An easy way, you know, the patient is on her back. So the esophagus is straight here. I'm injecting some fluid, and you can see since the patient is on her back, whatever it's pulling, that's the posterior wall of the esophagus. We're going to go anterior 1 to 2 o'clock. So we're going to create a bleb here. I'm going to ask you for the needle to be out, and we're going to go perpendicular to the wall, and we're going to start injecting here. Go ahead.
Which wall is this? Anterior or posterior?
Anterior. It's an anterior wall.
You can see it, but for the audience.
Yep. Go ahead and inject the whole thing.
The fluid was pooling on at 6 o'clock.
Mohan, can you bring the microphone closer to your mouth, please?
Yeah. So
now we can hear you.
Once he was instilling water in the lumen, the water was accumulating at 6 o'clock. So that was posterior. And also with the bulges of spine, we could make out that it is posterior at 6 o'clock. So he went bang opposite and towards 1 or 2 o'clock, because the accessory will come out from 7 o'clock. So it is easy to make incision at 1 or 2 o'clock. So anterior myotomy is at 2 o'clock, posterior myotomy is at 5 o'clock position.
So here we use saline for the blood, so you gotta work quickly here before this dissipates. So I usually have the knife ready, everything is ready, so that we can go ahead and do the mucosal incision. Knife out, and it's gonna be a, knife out please.
Knife out.
And we're gonna keep it out throughout the procedure, okay? And we're gonna go where the blood here is, and I want to get to the submucosa with this, and this is a longitudinal incision. I'm pushing the scope down, so the force is down rather than in towards the muscle. So you're cutting it down?
Downwards.
Downwards, and we only want about 1.5 centimeter, not longer. So that's probably enough there. And if you make it longer, what will happen? I mean, it's just longer time to close it, but you also don't want it to be very small, because if you have too much tension, trying to, to squeeze yourself in, you're gonna also extend it, kind of shear. We don't want that. So what we're gonna do now is so that was an endocut Q mode for the mucosal incision. Now for the rest of the procedure, I'm going to use a spray coagulation mode. And for the entire procedure, we're going to be using this knife you're seeing here. It's the triangular tip knife. And so one knife for the entire procedure. So now what I'm doing is I'm just dissecting some submucosal fibers to create some space for me to put my scope in and enter into the submucosal space. There is a bit of a learning curve.
Can you focus on his foot, please? Foot pedal?
What's the question?
What do you want? The foot pedal.
No, that's the only tip. We can't focus there. It is just like a normal RB foot pedals, yellow and blue. So once he is using spray coagulation,
that is what I wanted to say, that when he is using the blue one,
and while he was cutting the mucosa, he pressed the yellow one. So this is a very important step what Moin is doing. He is not trying to jump into the tunnel, but he is dissecting at the level of mucosal incision, so that there is a space which is created. Now if you try to go inside the tunnel without dissecting what he is doing, you will mechanically enlarge this mucosal incision, which you do not want. So always better to do dissection at the end, at the mucosal incision side, which Moin is doing. There will be some minor rules which is of most significance. It will be stopped by the scope tamponade itself once we get into the tunnel.
So you can see here, I can see some fibers. You can see the submucosal fibers here. So I'm just gonna use my cap to move a little bit to the left, to the right, and cut these fibers here. And after we cut these, we probably will be able to get in.
Yes.
So I'm using the cap to wiggle to push the both walls away and to...
So when did you cut some of the fibers also here now?
Sorry, can you repeat that?
Did you cut some of the muscle fibers here?
No, we don't dissect. We don't want to dissect. We want to try to avoid that because so here we're getting a little bit of resistance, which means we have to cut a little more of some of these fibers here. Again, I'm only cutting the submucosal fibers. And after we are in the tunnel.
So these are the submucosal fibers, nothing to do with the muscle.
Yeah, so we'll stay in them, after I stabilize my scope, we'll be able to show you the anatomy better. Just give me a minute, because here we're barely in.
So Moin, can we inject here? Because
would you prefer injections?
We will. You know, since now my scope is still not in the best position,
okay,
and I can see the fibers, so it's not a big deal.
Yes.
After I get in, we will be able to do whatever we need to do, but let's just stabilize the scope.
Yes.
So the most important safety aspect of this procedure is that we have to protect the mucosal layer. It's what we talked about in the morning with the hands-on session. So we're going to cut the submucosal fibers and we're going to cut the muscle. So if you hit the muscle, it's not a big deal. We're going to cut it anyways. But if you hit the mucosa, that equals a perforation in submucosal endoscopy and colon. So here we're gonna, so now we're gonna inject some blue dye, and the reason for that is you want to, so this is here the plane where we're gonna dissect, guys. See here, where my knife.
Johan, for the audience, we're getting some flashes of light. What is the putty he's using then?
Pardon?
We're getting some flashes of light. This is the putty. What is the putty he's using?
That is spray coagulation, so you get a spark-like picture because it is like APC, non-contact method, where if he is not even touching the fibers, it will destroy the fiber when the current is passed.
That's right, but what is the putty he's using for the
blue one? The blue one.
For all consumers, we're gonna try to stain coagulation blue.
No, we know.
Let's see if this works.
It's for teaching session,
So this is the technique what Moin has described, where he can inject he need not to instill the saline between mucosa and muscle. Even the power of the spray which is available into the scope, that is enough to create the cushion, the water cushion between muscle and the mucosa.
So that's very interesting. You just inject water and it flows into the submucosa. That's it.
Yes.
That kind of saves a lot of time trying to exchange. So now, guys, if you just let me explain this for a minute. So now this step is called submucosal tunneling. So again, what I'm doing here is I'm cutting the fibers at the level of the muscle. The mucosal layer is at 6 o'clock. The muscle layer is at 12 o'clock. I'm cutting at the muscle layer, and that protects the mucosa. This is a very essential step.
Yes.
The second important thing is I'm not working from this distance, because look at this. If I'm cutting like that, this knife is heading towards the mucosa.
Yes.
What you want to come closer and use your large wheel to look up, and then that way.
Show the hands, please.
Yeah. So here I am further. So I push in and look up.
So you're going towards
towards the muscle, and now we're working. The angle is towards the muscle. So there's no way we're going to hit the mucosa this way.
Can you show where the mucosa is?
The mucosa is
6 o'clock.
This 6 o'clock here, and this is the muscle.
Yes.
So if I don't show you if you don't see the mucosa, that's a good thing. So here, once you get used to this, you can use it like an APC. You can really paint. And here in the esophagus, although we see vessels, for the most part they're small vessels. Sometimes the vessels are large. You can't really go this fast once you're in the stomach, because there are usually large vessels in the stomach. You can hit them. You guys see this vessel here?
Yes. I see a vessel there.
So this is a relatively small vessel. So what I do is I'll just hit it with this, and it coagulates it. In the stomach, once we see large vessel, and you'll see them soon, we're going to use the coagulation grasper to prophylactically treat that muscle. So here you can see we're going steadily towards the LES, and once I'm closer to the LES, I'm going to slow down. But you see here we're just going close to the muscle, and it can happen pretty fast. And this is maybe a little of a larger vessel, but you can see even in the esophagus you can just use the knife. I'm always aware where I am. So here we're about 35 centimeters. And the G junction and the LES will be around 38. So in a little bit we'll slow down because the loop.
Are you pumping water too? Are you pumping the 3D water?
Sorry, what's the question?
Yeah. So are you asking that how he's creating the water cushion?
Yes.
So he's just spraying the inbuilt water pump of the scope to create the water cushion.
So guys, you see here these vessels, they're a little larger. So we're going to use the coagulation grasper. We're going to change our settings to soft coagulation mode.
Show the hands and the settings, please. Please show the hands and the settings.
Once you've shown the coagulation of the vessels, we'll be shifting to the next room. Dr. Amit is ready with another patient, but first because until you complete the tunnel, we will show some his technique of tunneling, and then we'll come back to you and we'll switch. Is that okay with you?
When Amit is here, you go with Amit.
Okay. So after you show the point.
Okay, and let's
The hands in the hands.
So, okay, rotate a little bit more. So rotation has to be slow because this can go crazy.
Yes.
Close.
Show the rotation, please, for the audience, please.
Okay, we already rotated and have the vessel. So the trick here is you want to pull back a little bit like this, so that the current is concentrated at the V. The current density becomes larger, and then we're gonna tap 1, 2, 3, and then open. I keep it open. No, I keep it open. Sometimes if there's bleeding, then you just go and tamponade it.
That's it again.
Close. And we have another vessel there. We're gonna try
to take this amount of tissue should be there.
Close. Okay. Open. Close. Open. Close. I think you're good to go to the other room and then...
Okay, thank you, Mohan.
Thank you.
I think you're ready over there. So let's switch to the room.
Hello, are you audible in that? Yes, you are audible. Okay, so Amit Mahadev here is ready with the next patient. In the back. Ravi is going to give us the history.
Hello, can you hear me?
Yes.
Yeah, okay, hello. This is a 24-year male who presented his history of retroesternal burning and history of food bolus infection. On evaluation, gastroscopy was done, which revealed esophageal submucosal lesion involving 1/3 of circumference at 24 to 27 centimeter from incisor. Radial US was done. It revealed heterogeneous hypochoric lesion, which was originating from muscularis propria, and it was of 2 into 3 centimeter size. There was no regional lymphadenopathy. Leiomyoma was the diagnosis suspected. CT chest was also done prior to coming to our hospital. It revealed soft tissue lesion involving mid-esophagus. The image is endoscopic image and ultrasound image is shown over here. Over to Dr. Amit Mahadev.
Hello Amit, hi. We can't hear you. Something wrong with this. Same problem. Mangeshkar having the same problem.
Can you just see if this mic is on?
Oh, yep.
अपने सारखं धरता येणार नाही तुला.
Same.
Somebody for the mic.
Now we can hear you now.
Can you hear me?
Yeah, I can hear you. Go ahead.
Okay. As you have seen here, this is a patient who has got a...
Can you keep it closer to your mouth? No, I mean... Harshal, you have to turn towards Amit and keep it close to the mouth. If you see in the camera, then probably, yes, something, yes.
That he will not be able to do close.
No, Shahzad can do that. Shahzad can do anything.
Okay, anyway, let's start.
Harshal, you are right. Perfect.
So you must have seen from the history, this is a patient who has got a submucosal tumor in the mid-esophagus. And the tumor appears to be quite big. It's approximately 3 to 5 centimeters long, probably 2.5 centimeters wide, and it appears to be arising from the muscularis propria of the esophagus.
Harshal, just remove the microphone now. Probably just yes, we can hear you now.
Now you can hear?
We can hear you.
And it appears to be arising from the muscularis propria of the esophagus. Now before I begin, I want to first say that I am extremely proud and happy to see the second international conference which Amol is holding on NBI, ESD and Pune and third space endoscopy. There have been a number of students which have been trained at our centers since last 25 years. All of them have learned endoscopy very well, but there is one more thing which all of them have learned, which is a clear reflection in this conference from Amol, and that is passion. And you can see the amount of passion which Amol has put in this conference, and he is putting in year by year, train people in this very exciting field of endoscopy.
Shahzad, थोड़ा सा दूर कर दो माइक्रोफोन से, थोड़ा सा दूर, तो बस that should be fine. Thank you.
Okay, and all these techniques are basically related to third space endoscopy. Unfortunately, I could not give you a lecture on third space endoscopy, before Moyen and me started these procedures, because third stage endoscopy all relates to endoscopy in the submucosal tunnel. ESD is not classically third stage endoscopy, it is a prelude to third stage endoscopy. But submucosal tunnel is a very important factor because once you enter the submucosal tunnel, the mucosa becomes a flap, and then whatever surgery you perform within the tunnel, whether you do a tumor or you do a myotomy or you actually remove the muscle or you do a mediastinoscopy or even a peritoneoscopy, finally when you complete the procedure, the mucosal flap seals the tunnel. And that is the whole secret and the whole fun in this submucosal tunneling endoscopy, also called as SUMO procedures, SUMO. And this is what is third stage endoscopy. Now here, you see here, the endoscope is again a high definition, high magnification endoscope from Olympus. This is a 190.
No, you can't see the microscopic images.
It is a 190 HQ endoscope. Yes. And there is a cap, transparent plastic cap which is attached to the tip. I pass the scope in the mouth, patient is in the left lateral position with endotracheal anesthesia. There is carbon dioxide which is being insufflated, not air. The carbon dioxide is being insufflated at a very low rate, not high rate. And as I am entering inside, you already start seeing this bulge. You see here, just now I am at 20 centimeters. I am going in, going in, going in, going in. And at 25 centimeters is the upper edge of this bulge. Then I am going beyond the bulge. Fortunately, my scope is going there. It looks to be quite a big submucosal tumor, and this seems to be the lower edge. This is somewhere at 30. So if you see, the extension is 5 centimeters. Possibly the place from where it is arising from the muscle could be 3 centimeters, but superficially it is 5 centimeters. So it is a big tumor. Now I am likely to face some challenges over here. The challenges are more going to be two. Number one, not to dissect it, because dissection would not be so difficult. But because the tumor is large, I am likely to find big blood vessels which are supplying this tumor, which can bleed. And second is, going beyond the tumor for dissection is going to be a little difficult, because it is too broad. If the tumor is not broad, then we can go very well beyond and dissect it away from the mucosa. Now my aim is to create a submucosal tunnel and approach this tumor through the submucosal space as if we are doing underwater swimming. Okay, so around 5 centimeters proximal to the tumor, somewhere over here, my plan is to enter the submucosal space. But if you see below at 6 o'clock, there are these two vessels here. Can you see this, SP?
Yes, we can see that.
Yeah, and these vessels can sometimes cause brisk bleeding as we are entering inside the submucosal space. So I am trying to select the place.
So for this tumor, you have to go from the posterior wall.
Yes, but this is not necessarily the posterior wall. I have turned the patient in the left lateral position.
Okay.
So whatever wall it is, I am trying to bring the tumor posteriorly. Now I'll tell you the reason why. Because I am using an Olympus endoscope.
The accessory will
come out at 7 o'clock position. So for me it will be easier for dissection, then I am going to dissect in this way and this way. So I am going to pull 5 centimeters proximal to the tumor, and the first step is to create a submucosal cushion by injecting a solution of normal saline.
How many centimeters from the incisor are you?
From incisor at 20.
20 centimeters. So it's just below the peak of fringes.
Tumor is 25. Okay. Sometimes what happens is, if the tumor is small, in the submucosal space, you tend to lose the tumor. You keep on going inside and then you go by the side of the tumor and the tumor remains behind. Okay, so see what I'm doing now? Over here, I go here, a little bit down. Yes.
Can you focus on the hands of Shahzad?
This he's just injecting.
No, but I just wanted to show.
In the 20cc series, I am trying to push the needle inside so that the fluid will go ahead as much as possible. Actually,
see the amount of force he is using.
Very well by using simple Olympus equipment. Here I am using an Olympus needle, 23 gauge, and then I can use a triangle tip knife. But because more...
So Amit, how much fluid do you use for STAR?
25 cc, 30 cc.
30 cc, okay.
35 cc, it doesn't matter. Until they feel that there is sufficient fluid. But now the fluid is so much that my scope is also not going.
This is another submucosal tumor.
Is there any mucosal injury?
No, that's it. That doesn't matter. That was because of the cap. So, Amol requested me that because Moen is now demonstrating with an Olympus equipment, he requested me to demonstrate with the herbal equipment. So, I am going to show you a different knife now than what Moen is demonstrating. Yes, out. Knife out, please.
So, Dr. Maida, you prefer this or I type?
Oh, not I type. I always prefer a T type. Continue.
But here you have to exchange the knife every time.
Huh?
Amit, you have to exchange the knife here?
No, here you don't need to exchange the knife. Okay. That's the advantage actually.
He is using a hybrid knife, hybrid TF.
This is RB hybrid.
So you have got both, what is
I can see the color now, I can see the color.
Proper? What are you asking?
Using a hybrid knife, they wanted to know about the hybrid knife.
So Amit, you are withdrawing it rather than pushing it. So this is also a technique?
Okay. But this knife doesn't seem to cut.
Would you like to go to the initial part with the petty knife?
Current being passed on the knife. See there? Look here. Look there. There is no cutting at all.
Now it has started.
Can somebody see the electrosurgical unit, please?
That should not happen, no? Connection problem? The beginning one? Is the knife working or not? Otherwise I'll use Olympus.
No, I think it's...
Is Neela there?
Yes, sir.
I can hear you, but I can't see you. You're Mr. India. We can hear you, but can't see. Now we can see you.
What?
They can't see me, just here.
Anybody here will know that it is Neela. Now, if you see this layer inside, can you see the white fibers?
Yeah.
Yes.
White fibers is the lamina propria. That's not the muscle, huh? And it's important to cut the lamina propria if you want to enter the submucosal. Many times what happens is we are too superficial and we don't cut the lamina propria.
So Amit, you are cutting both ways.
Huh?
You are cutting both ways, upwards as well as downwards.
Yeah. Now you see that I have entered the submucosal plane?
Yes.
Out please.
And where is the mucosa now? 6 o'clock? 12 o'clock?
Yeah. 6 o'clock. Mucosa is at 12 o'clock. You see the muscle below?
Show the hands of Amit. The tricks are in the hands, you know. See, he's using the scope, not the knobs. We can't zoom it, I believe. See his hands.
Amit,
Hands of the hands.
what currently are you using? What's the settings?
He's using a good
Q.
Yeah. Effect 3.
I will tell you the exact setting, but first let me go inside. Now see, I've gone in. Now we are well inside the submucosa. You can see the circular muscle fibers below. Is the cut interval fast like ours normally? Trouble 4 असतं ना.
So Dr. Maidel, what are the tricks if
What are you saying, Dilip?
yeah, what are the tricks if the scope is not going into the tunnel easily?
Oh, the most important thing, Dilip, is to get the proper leg below the mucosal incision and make sure that you have cut the lamina propria. Because most of the common mistake is beginners do is not to cut the lamina propria.
Sometimes it's a thick white layer.
Yeah. And as Moen told you, we have to remain as close to the muscle as possible.
So, Amit, which side to avoid? 12 o'clock or 6 o'clock?
The vessel. I have created a cushion. And now, by the side of the vessel, I am just touching my knife.
So what Dr. Maidel is showing is that, and he used force coag, right?
I use force coagulation.
So for this vessel, he used force coag. If the vessel was even bigger, you would probably use coag grasper. But with coag grasper, it is always soft coag.
Are we going in the right direction, Dilip?
Can you put some more here?
Are we going in the right direction? Because if
Which direction to avoid? 12 o'clock or 6 o'clock?
Which?
Oh, now you have to avoid 12 o'clock.
12 o'clock.
12 o'clock.
Because you see the muscle.
Muscle is at 6 o'clock.
So opposite direction is the mucosa. But remember one thing, that this is a patient of normal esophageal muscle, not Acalasia cardia. So normal esophageal muscle is also very thin.
This is very important. When we are doing proven Acalasia, the muscle layer is very thick.
So you can do a little bit and able to the muscle. When
But even if you have a nothing is going to happen.
Not yet.
No. It's not. It's just
not usually. Let me see where. Oh yeah.
Amit, why are you turning the scope?
Not at 25.
Yeah, he's not turning the scope. Like, the base way is to see the muscle. They are circular, so we have to be perpendicular to it. That's the straight path.
Think of this depression in the center.
I'm seeing some abnormal vessels now. That means I'm involving in a tumor access.
Yeah, that's a good suggestion.
Yeah.
They are thicker vessels than what you find.
Neovascularization has started.
What is the suggestion?
But these vessels, if you see, they are different. They are thicker than what you normally find in esophagus.
They must be feeding the
Yes, so probably we are nearing the tumor. That's what Dr. Maidel is saying.
And somebody switch off the microphone from the other end, please.
I think we are just 5 minutes away from the tumor. If I am...
Without traffic jam of Pune.
Can you we are shifting to the next room and we'll reach the tumor and we'll stay with you.
Okay, thank you.
I don't know about my mic.
See you in 5 minutes.
Thank you.
So I think submucosal injection and snare is what I'm thinking.
Hello? Yes? Hello, can you hear me, sir? Yes, go ahead. So, the other case we are going to present a 55-year male who presented to us with a history of long-term constipation and occasional per-rectal bleeding. On colonoscopy, we found a flat adenoma in rectum which was of 1 into 1 centimeter.
We did an endoscopic ultrasound, which revealed a hypoechoic lesion arising from the mucosal layer. Submucosa and muscularis propria was free. There was no regional lymphadenopathy. Plan is to do NBI and ESD. Now over to Dr. Iyer.
What happened? No one was doing all.
That is going on. We'll take you over there also.
Okay.
Hello.
Hi, Prasad, you're on.
Yeah, can you hear me?
Sure, we can hear you and see you good.
Okay, great. So we have Dr. Bhatt, Dr. Adi.
The focus is on
So this is the dentate line, and as we go in, we actually see before the proximal valve of Houston, we are seeing this, I would say maybe 15 millimeter to 20 millimeter lesion, flat lesion, very distinct from the surrounding mucosa.
You have a soft cap on?
I do have a soft cap on, and I'm a fan, I must say, of the cap. It does allow me to sort of flatten the mucosa and take a better look. And as you can see, there's a clear demarcation between the lesion and the rest of the mucosa. And there appears to be this central depression in the lesion. And when I spoke to the physicians here, the lesion has not been biopsied. So this is not a biopsy residua or a sequela. And so that obviously raises concerns if you were to go from our discussion from last time. So I'm going to turn on narrowband imaging and again sort of go up close. I'm just going to gently wash the lesion. And we can engage the near focus feature. And again, as you can see, there is a distinct difference between, so now I have normal mucosa on the right half and the abnormal mucosa on the left half of the screen, clear demarcation, and this is the central part of the lesion with some added abnormalities in terms of loss of vascular pattern and abnormal vessels. So anytime we see a depression in a colonic polyp, we do worry about invasive disease.
That's invasion.
So there has been no histology. Endoscopic ultrasound has been performed suggesting lack of invasion. So our plan is to remove the lesion. Questions and concerns?
There are two concerns from the hall. Dr. Manish? Yes, so something I was going to ask myself, the whitish specks around the lesion, Dr. Manish feels these are chicken skin-like appearance. Your views on these whitish specks around the primary lesion.
Go ahead.
Dr. Prasad, can you hear us? Because this colonic mucosa is normal. Dr. Prasad?
Yeah.
Rupa, we can't hear you. Rupa, we can't hear you. Can you hear us?
Yeah, we can hear you. She
can hear us
right now. Can you?
No.
Hang on just a minute.
Rupa will put them charab, don't worry. No, we can't hear you.
Okay, hang on just a minute.
The person Mahesh had a good laugh. We can't hear, something wrong with the microphone system there.
Yeah, we are just trying to fix it. Give us a few minutes.
But we can hear you, Dr. Prasad, very well, so
yeah.
You can answer in lieu maybe.
You know, to me this doesn't appear to be necessarily an abnormal pattern. I'm curious to see what Saichiro feels.
Sometimes it is considered to be a sign of submucosal invasion, this chicken skin sort of appearance. So your view of these findings in the adjacent mucosa?
Yeah, I'm more concerned about the central depression here in the absence of any biopsy.
Yes, in addition to that, yes.
Yeah, can you hear me now?
Yeah, finally on.
Yeah. So I think it's a valid question that this is the chicken skin appearance and this could indicate submucosal invasion. The second is that the lesion is quite friable, if you see. With just the touch of the scope, it is bleeding. And there is a central area, if you can just focus over here, Dr. Prasad.
occurring over there.
Yeah. So just above the blood thing, you will see some kind of an amorphous spit pattern as well. So there could be submucosal invasion as well, and I think
Rupa, would you also call it a small areas of avascularity or avascular areas?
Yeah, absolutely.
that is the amorphous kind of area, very small areas, but if you just see right in front.
Yeah,
exactly.
Beautiful demonstration.
Yes. So you don't see the vessels there. So this amorphous or partly or mostly avascular area would indicate a submucosal going through.
Would be indicating. So in this patient, not one is indicative, but the chicken skin appearance around, the raised lesion, the irregular vessels, and a small amorphous area with friability could suggest submucosal invasion.
That's Rupa, this is observation, but do you have a logic for why does the amorphous lesion be the submucosal invasion? And why do you have chicken skin appearance? The logic behind it?
I'm not sure about that.
So, Saichiro, do you have any ideas in terms of, do you agree with what Rupa just said? Do you have concerns about submucosal invasion?
Yes, of course. Now, first of all of the chicken mucosa doesn't necessarily indicate the submucosal deep invasion. And then in this area, I think this is just a mucus. Now, please try to push out again. And at the first time, I could figure out type 2B basically in genetic classification and type 2 in the mass classification. So I think that it is basically the intermucosal cancer, submucosal slight invasive cancer. But of course, genetic classification 2B includes some possibility of the submucosal deep invasive cancer. So from a Japanese endoscopy point of view, so I would like to recommend the pattern diagnosis.
Dr. Abi, would this indicate a massive submucosal invasion?
No. Well, basically, I think that this is confined to mucosal, slight submucosal less than 1,000 micrometer. So I think endoscopic resection is a good indication. But there's some possibility of the deep submucosal invasion. Now, of course, in this case, the lesion is very small, less than 20 millimeter in size, and definitely Prasad can perform the umbilical resection using a conventional EMR technique. So I absolutely agree with his plan.
So one of the things I'm trying to demonstrate here is that the lesion is far away from the dentate line. And I think it is, in my mind, best approached in a retroflex position, I think.
Dr. Prasad, one question from me and one from the hall.
Yeah.
If there is some mucosal invasion, a suspicion of significant, then would it be wise to subject this to endoscopic resection?
Yeah, there are pros and cons in here. Right now, we don't have any histologic evidence at all.
No, I think, Dr. Prasad, the best part is when you remove this lesion, the best you'll have a histology.
Yeah.
Rupa, we can't hear you. Closer to your mouth.
The best part about removal here will be that we'll have not only the histology, we'll have the margins and what it shows, and then the future can be planned accordingly. I think.
But here the margin is not important, the depth is important.
1:10,000.
Yeah, and yes.
The depth is important.
Yeah.
Can you predict
So you can stage and you can. So that's the reason why we should go ahead.
One question from the
Can you predict the submucosal invasion by the Paris classification of this lesion?
There is a question, can you predict the degree of submucosal invasion by the NICE classification?
Paris classification.
Same.
So,
can you hear us there?
going to the next one.
They seem to have lost us.
Prasad?
Yes?
The question is, can you predict the invasion by NICE classification?
By the Paris classification, sorry.
Yeah, by the Paris classification, we can certainly predict the fact that there are some type of Paris lesions like 2B, 2C, even 1P, which are more likely to show submucosal invasion. Whether we can predict more than 1,000 microns or less, I don't think is clear.
No, I don't think we can. I don't think.
But yeah, this is a lesion that certainly could be invasive deeper. or at least into the
So we are Amit here now. Amit? Yeah, we switch to Amit's room. Nilay, you can go. So you have allotted this room to Dr. Amit? Can you see this? Nilay, we don't have your audio. Oh. No, Amit, we can hear you. No endo picture? No, endoscope picture is not there. We can see you, but now we have the audio. See what I've done? Okay, we can see the tumor now. I've separated the tumor from the surrounding tissues, but still some separation is required. Isn't it the beginning of the tip of the iceberg? Yeah, I think so. Good. Can you see the attachments in there? That's very encouraging statement. Nila, why did you burst into hysterical laughter?
Dr. Matthew, how do you prevent mucosal damage when you dissect on the mucosal side of this tumor? What precautions do you take?
See what I'm doing. I'm injecting.
This is not the mucosal side.
Yeah, see what Dr. Maidoo is doing.
As close to the capsule of the tumor.
And also he keeps on injecting.
And see what I'm using? I'm using now which knife? I'm using a knife which is similar to the IT knife from Oliver. But this is now from Barrett.
Yeah. So Dr. Maidoo, can you tell us what, is this a different knife than what we were using previously?
Yeah, previously was just a T5 knife.
Okay.
But see that, what's the question asked by Monish?
How do you prevent mucosal damage once you are dissecting the mucosal side?
Yeah, so now you can see that, what I'm doing? I'm using the insulated tip knife. So you can use the Olympus IT knife or you can use this knife, which is a new type of herb knife, which is a hybrid knife from where you can also inject. Now the big ones are coming, big ones.
Yeah, are you cutting the same way as like IT knife from the inner part of
the? What I'm doing, it's like ESD.
Yeah.
I go in that tissue.
Right.
What you can do is either hold it in a snare and then...
So it's clipping it close to the tumor.
Yes. And he's cutting from the inner part because the tip is insulated, just like IT knife.
Almost like enucleation, if you ask me.
Yeah.
What you do is you pull it up to the overtube and then along with everything you put it. Okay.
A little more injection. And now. But I need to inject, no? Okay, give Olympus IT knife now.
So now they are shifting to, is it IT knife 2, right?
Yeah.
Or nano? Which one is this?
IT knife nano or IT knife 2?
So they are using IT knife nano, IT knife 2.
I did a US. I bet 69. But
In esophagus, if you are doing on the mucosal side, nano is better than IT knife 2, right? Here it doesn't make a difference, big difference.
Because there is not much space.
Nilo, the tumor is very nicely exposed, but in this view, which side is the mucosa again? Sorry?
It's on the 12 o'clock.
Above.
On the 12 o'clock side?
Yeah.
Okay. It can become pretty confusing.
Yes. So best way is to take out.
Look at this, Vikram.
Yes, okay.
Now you can see, this is the muscle.
Now we can see,
Take
yes.
the knife out. This is the muscle.
Right.
The tumor. That is the mucosa.
Right.
Now we go here.
So now you are dissecting closer to the mucosa, on the mucosal side.
Hook the knife cut.
yeah, mucosal pattern.
See the current what Dr. Maidoo right now is using force coag because there are too many vessels.
Yes.
Normally you do it with endocut, but
Now you are using IT2?
this is IT2, right?
Now force coagulation.
Yeah, it is force coagulation
Yes.
because there are too many vessels.
Because of the vessels. So Nilo, this is Olympus.
This is Olympus IT knife 2.
So while doing the dissection, if you rupture the capsule of tumor,
Capsule doesn't matter. Provided you cut the tumor,
but even if you cut the tumor, what is happening?
then there can be seedling, no? There can be recurrence after a few years.
No, but if you remove the whole tumor, even after cutting it.
Then doesn't matter.
But see, not the tumor is being touched by the insulated part.
Yes. So basically IT knife, you cut it from the inner part.
the tip is insulated. So you just have to do a circular movement.
So it seems as if you are practically rolling over the tumor.
Yes, absolutely.
So
And you have to pull this knife rather than push.
Even this is like working like a PC, it's not touching your tumor. Yes, but very beautiful rolling over the tumor. That's not touching any movement.
But are you seeing my movements? My movements are with the right hand, huh?
What I was wanting to tell them that you should show the hands rather than anything else. We all know how you look. Hands on the right hand, especially the right hand.
I am not cutting with the endocut. It's only post-coagulation.
उजवा हाथ दिखाओ. Can we have endoscopy as the bigger PIP?
Yeah, we are change to another room for showing myotomy. Dr. Mohin is ready with the myotomy.
No, we are still seeing you actually.
Yeah, and after this.
Okay, okay.
Okay.
Hi, ma'am.
Hi. Okay. You can hear me?
Yeah, I can hear you, see you.
Okay, so we finished the tunnel, and let me show you. We're gonna go down here.
So that is the G junction.
So you see here, this is the LES.
No, we don't have the endoscopic images.
You see the endoscopic image? Yeah.
And the patient is lying supine.
Yeah. So this is the tunnel again. Once we reach here, you can easily tell this is the LES, and it's a little tight. We kind of maneuver around it and see the gastric tunnel, and we see we have about a couple of centimeters. You can see here we have a little bit of a blanching on the mucosal side there. So when we looked on the other side, we also saw blanching, like coagulum. So Mohan was of the opinion not to put clips. I just put clips, for safety reasons. So I just put a couple of clips there.
So now that is also a marker that you have gone way beyond the G junction, so around 2 centimeters beyond that.
Yes, exactly. So we're reassured this is enough gastric tunnel there. And again, these clips, I place them prophylactically. I've seen some of these open up and they become pretty large. Mohan has a different opinion, but I think it's not wrong to just to be on the safe side. The other thing that happened is that the peak pressures went up and patient had some subcutaneous emphysema. Again, we're using CO2, so what we do is we stop the procedure, they increase the minute ventilation, and the patient will just breathe it out, basically. And we're back to peak pressures are acceptable, the CO2 is acceptable, so we are proceeding. So again, this is a team effort with need to have good assistant. Mohan is really helpful with his expert eyes, and we have expert anesthesia, so the whole team has to be alert and helpful. So here now we're ready for the myotomy, again anterior myotomy. So this is the incision here. So we're not gonna start the myotomy here, we're gonna start with the distal, and this part with a intact muscle will aid in closure. It's a flap closure as well. So we're going to start here at this level. We can see the muscle. So my practice is to do selective inner circular myotomy. And to start with, once I reach the lower esophageal sphincter, I turn, as you can see here, the longitudinal fibers are very thin.
And you can also see the pericardium just behind that longitudinal muscle. If you are carefully visualize, the heart is beating.
You can see the pericardium.
Yeah, and you can see the longitudinal fibers there.
Now you can see,
right?
You can see the pericardium there.
Very, very thin layer of longitudinal fibers. And even the inner circular here, Mohan, is extremely thin.
Again, you can see the pericardium here.
But it will thicken a little bit here. So I'm again doing, and this is another reason, you see how we have to protect the mediastinal structures. So
is it possible to do a pericardiectomy?
You can see carefully how Mohan is selecting the space between longitudinal and transverse muscle fiber. He's not even seeing the pericardium which is beating behind it, but he's just keeping the blade between the longitudinal. So it is actually a safety check whether you have proper depth or not. So leaving behind longitudinal muscle are not of any clinical significance, but yes, they act as a safety valve for us to say that yes.
But inadvertently they are getting cut because you can see the pericardium.
Yeah. So they actually are like curtain, the longitudinal threads which will separate ultimately.
Yeah, they are very thin, and just pushing down the scope with the cap, they will shear off. Look at this here. You see this? We didn't cut them.
Pericardium, you can see the pericardium.
No, okay, let's, we don't have to see, that doesn't do anything for us. So what we're looking at is the longitudinal fibers. We didn't cut them, but they're separating. So that tells you that it's really not important to cut them, but as a safety net, avoid cutting them. They will shear on their own.
Yes.
I'm sure tomorrow you'll be doing pericardiotomy by Mohan. Mohan?
Yeah, at least biopsy is everything we can do, but later on.
Yeah, later on, after hours.
Pericardial, cardiac tamponade.
So here we have to be, one thing we have to be careful with is when we are cutting the muscle, our force is towards the lumen, which means towards the mucosa. So you got to be very careful here, especially with a thin muscle like that. I mean, this is extremely thin, which actually makes it more difficult. And we also want to make sure we keep centered. We don't want to go laterally a lot, like here or here. We want to stay in the middle of the muscle to avoid hitting the mucosa laterally. And here we're getting still a little far away. It's really hard to do selective myotomy with this.
Full thickness here.
I like to avoid this if possible at this stage.
Now you come to the LES. You can see the constriction very well. And if
not yet. I think it's just contraction. You know, the LES is going to be here. So
do you think LES is a single point? Or
no. I mean, when you look at manometry, you see the LES is a 2-3 centimeter structure.
Exactly. So that's the LES complex starts around 2 to 3 centimeter above the GE junction, and it extends 2 to 3 centimeter beyond GE junction. So this is what I meant was this is a constrictile segment which constitutes LES.
Segment begins.
You know, here actually, anyways, I don't think it's possible to do selective.
You can see the real medial segment behind.
Given how thin the muscle is, amazing.
Very thin.
You'll think that these patients, typically have thick muscle, right? Thickening up a little bit here, which hopefully will make it a little easier, but we're doing well. So again, this procedure is about accuracy, knowing which layer, having a good team, extra pair of eyes, sometimes you get fooled. And here the cut. You see I don't have a lot of lumen, but you want to avoid cutting and we're using cotter. The mistake that happens with beginners is that they try to shear the muscle rather than cutting it, and to avoid that, it's just slow cottering. I always sometimes back up, make sure I'm in the middle. You see muscle here, we're in the middle, we're good.
Mohan, we practically don't even see the longitudinal stripes of muscle.
Yeah. Now we're close to LES. This is a full thickness myotomy now.
Yeah, so what's that bulging through? That's the pericardium?
No, we are now way beyond the pericardium. We are at the pleura level.
That's the pleura.
Yeah, so this is why some of these patients will have chest pain after the procedure. They have pleurisy, because when you're doing this, some cautery touches the pleura, and they will have some pleuritic chest pain, which is pretty common after this procedure.
So now we are working next to the pleura right now.
Yes, exactly.
So you see all the dangerous anatomical structures, pericardium, pleura, and then...
So let's clean the knife. We're going to clean the knife here.
So Amal wants us to move to Prasad for a minute, and then we'll come back.
Okay. Thank you.
Water. Yes. Okay.
You're on, Dr. Prasad.
Okay. Hello, can you see us?
Yes.
Can you hear us?
Yes, yes.
Okay, so here I am going to try and inject this lesion. You just push this just a little bit on the inside. There we go. Needle out, please.
Your plan is EMR or ESD?
EMR, I think just because of the size of the lesion. So we're going to try and inject, please. Yep. And stop there for a minute.
Use a snare or bands?
I'm sorry?
Snare, band?
Just snare. Inject again.
Nice lift.
Okay, stop. So as you can see, we are getting a good lift. I'm going to just do some from the antegrade side as well.
Dr. Prasad, in this lesion, if there was not a good lift, then
I think I would get some histology.
Then you walk up the stairs.
And then stop. Yeah.
And then you, in this lesion, then you about resection attempts.
Yeah, probably. There you go. Okay. Okay. Stop. Yeah. So I just want to make sure that this is lifting on all sides. As you can see, it is somewhat friable.
Not always, but that's one of the. Dr. Prasad, do you feel this is actually getting buried rather than lifted, particularly the central part is teething?
You know, if you look at the side, that's why I'm injecting on all sides. Go ahead. And stop. Needle back.
Are you happy? Yes, except for the center.
But as you can see, the center is not lifting as well.
Exactly.
As the periphery. There is a lift, but the center is not lifting as well as the side. I have to say that.
So that's what I was, I thought the center is holding it down and it's getting buried the more you are injecting.
Inject 2 cc's, please. Okay, stop. Yeah, you're right. So certainly we get the sense that the center may not be lifting as well as the side, which again sort of goes in favor of deeper invasion. Saichiro, what do you think?
Maybe.
He's not convinced.
We can't hear him again. So the chicken skin appearance and the amorphous appearance show that there's deeper invasion.
So now, you know, looking at it from this angle, the whole lesion does seem to have lifted. At least that's my impression from this angle.
Vikram, do you think the center is lifted? Center of the lesion?
Well, yeah, go ahead, inject. Stop. Stop. Okay. Let's try the snare, please. So again, I think there has been a lift, sort of a general lift here for sure. It's not that it hasn't lifted at all. And we will try to resect the lesion with a snare. I'm using a 20 millimeter oval snare. The only challenge I anticipate here is the flatness of the lesion and how well we actually get the lesion. Naresh, if you wouldn't mind, maybe just push this inside for me. Okay, snare out, please.
So for a more flat lesion, what should be a good snare?
I think something like a braided snare, in my mind, would be a good.
Which this is?
Which this is, yeah. Close, 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 close. Got it? So I have the lesion here.
Prasad, how do you decide how much you have caught, the depth?
I'm sorry?
How do you decide how much you have caught in the snare, the depth?
Yeah, so again here, there are two ways of doing this. I think here we are seeing normal mucosa around, And we could have marked the lesion, but at this point, I think I have little normal mucosa and mostly the polyp. Any thoughts from your end?
I'm talking about the depth.
Yeah, the depth I think is from the fact that we
lifted it, that's it.
Yeah, it lifted. So
good.
So we are applying a little bit of pressure, and I'm going to start cutting here. Cut, please.
That's good.
Okay, so I think we have
very well done.
We have
good. Some small tissue left over there, I believe. On the lateral side on 5 o'clock, the lesion.
So I'm washing the base.
7 o'clock.
So this might be a piece left behind, so it's not clear after the. So we'll try and get that as well. Can you just push that in? Okay, open. That's it, yeah. Just a little bit. Close a little bit for me, please. Just close a little bit. And close. And close. I'm just looking at that nubbin. We could just take it out with the tip as well. Yeah, just burn it. My preference is usually to resect some of these. We'll give it one more chance here. Oh, close, please. Yeah, it's going to slip off here, I think. So tip of snare out a little bit. Tip of snare.
Can you inject that area and make it a now?
Yeah, I think it's just too small to inject. In fact, I think most of it has been cut already. So I'm snip out a little bit more. Just that's it. Thank you. So I'm just going to burn.
And what's this mode you are using to spray it?
So this is the same quag mode.
Same
which
quag.
we used to cut. Yeah.
Right.
Okay. You know, I'm not really sure. There's no bleeding. We are looking at this base here. I can maybe just cauterize it out a little bit, please. Snare, tip of snare out. A little bit more. Yeah, that's good. Are they moving to the other room? That's fine. I think we are just causing bleeding than any. Let me just unretroflex here.
I think that's just mild lesion to stop by itself. What's that?
I'm sorry?
I think it's a mild lesion to stop by itself.
Yeah, and that's what I'm trying to assess. And now I have it on end on. And tip of snare out, please. A little bit more out, little bit more out. Yeah, thank you. I'm not. Are they still with us?
Yes, we are with you only.
Okay,
No, I know he is back with you. So, Mohan, we are with you now.
So we have completed the myotomy, so we'll show you the completion.
We are
what I was thinking.
No, we are there.
Can you hear us?
You can actually just put a clip.
We are hearing you but seeing the other room. So
clip.
Can we shift to the other room?
Yeah, we're going to try and close this area with a clip.
Insufflation is off.
Okay.
Now we are with you.
I think we're good now.
Now we are with you, Mohan.
Okay, so now we'll show you the
I just don't want
last
to like
part
watery over and over
of
again.
mucosal incision closure, but before that we'll go into the tunnel and then we'll show you how the myotomy was completed.
So this is here the flap muscle?
Yes. And from here the myotomy has started. So it has gone down. This is total full myotomy. Then there is a GE junction over there. Because of diaphragmatic contraction, you can still see some of the resistance over there. So that is the beauty of POEM over LHM, that you don't touch the diaphragmatic crura or touch the phrenoesophageal membrane. So most of the anti-reflux mechanisms are still intact. So you need not to do fundoplication. So here you can see the end of the tunnel over there till the 2 centimeters beyond GE junction, completely separated. When you are done, fantastic.
Can you see the clips on here?
It will be on the other side. You can see the stitched part from in this side.
Yeah.
Show the back of the mucosa where was the.
Yeah, we'll see. Show that. I always take a look at the myotomy, make sure I didn't leave anything at all. And sometimes you get these little fibers there, but I think that's really not much there. But when you're in doubt, I usually just cut them. So I'm going to cut these little fibers that are remaining. The position for the gastric myotomy was not easy on this patient. I had a lot of torque on the scope, and my large wheel was all the way up. So it wasn't easy to get what I want. But other than that, the procedure I would say was pretty uneventful. Okay, out. So I'm just going to catch these fibers here. So they're not responding like muscle fibers. But I see the layer of adventitia or serosa at this level behind, so I know this is nothing, it's not a structure behind that, right, Mohan?
Yeah, I think we are done enough.
Yeah.
So you can go into the lumen and see how much resistance.
Yeah, let me just do one more. So the enemy of good is excellent. Sometimes you do this and then you regret it later. But I just want to finish the job here. Okay. Okay. So we're going to go back to the lumen now, like Mohan is suggesting, to see that it's widely open.
It's completely open now. So the patient has not to worry about dysphagia, but only regurgitation may be some issue.
And our clips that we placed prophylactically are still there. So the next step will be the last step of POEM, which is closure of the mucosal entry. So it's good to use rotatable snares that open and close multiple times to make sure you're getting adequate closure and adequate positioning. And there is some learning curve to this. It's not as easy as it seems. I start at the lower edge or a little bit below to help in approximation of the two edges. And so here we're using, this is quick clip 2, which is the Olympus clip. So let's actually clean give me the 60cc syringe. I want to just clean the channel.
We have a change of chairpersons. We thank the chairpersons, Vikram.
Sorry,
Dr. Manoj Sahu. And may I invite Dr. Pramod Shinde, Dr. Ajay Jain, Dr. Vivekanand Kulkarni, and Monish Chabra.
Open?
Now you can't use them.
Rotate, so it's like that. Slowly, rotate slowly when you rotate. Okay, close. Close now. Open.
Ajay Jain, somewhere?
No.
Not here.
No, we didn't want to deploy. Okay, you haven't used this clip before. You have? Yes. Okay, deploy it, that's fine. Deploy it. Okay, no problem. So we'll get the next clip. So this is a little lower than I want, but it doesn't hurt.
So Dr. Mohan, what's your preference, anterior or posterior incision?
Yes, so when I started doing it, it was all anterior. I'm a little faster doing anterior. Right now, we're doing a randomized trial of anterior versus posterior, and that tells us what's the best approach. Open. Open all the way. Yep, excellent.
Would you opt for a posterior myotomy in case of a post-Heller's myotomy pain?
Yes.
Release, yep. So, yeah, do you want to answer that, Mohan?
Yeah. So, once you are doing a Heller's myotomy, you are actually causing submucosal fibrosis in anterior plane.
Yes.
Because, you have done dissection over there. And then, poem, there is an option that you can go diagonally opposite, where the plane is more healthier, and then you can do a posterior myotomy in failed Heller's myotomy cases. So, if a failed Heller's myotomy case, preferentially we do a posterior myotomy.
Yeah, so important to ask the patient or and examine them if they've had transabdominal or transthoracic. So transthoracic is posterior. So you want to look at the scars basically, close please, if they are in the abdomen or on their flanks. Okay, release. And next.
So anyone who wants to do poem should be familiar and should be able to do it both ways, the anterior as well as posterior.
Yes, 100%. And if you do one, you'll be able to do the other. Your muscle memory, always will prefer the one you've done more, but once so it's just going to take a little longer. If you are able to do anterior, then you can do posterior on your own. So one thing is that...
Okay, so I think Dr. Amit is ready with that huge submucosal tumor, leiomyoma almost popping out now.
Okay.
You want me to go there?
This is, we're just going to continue closer, nothing fancy. Yeah.
So, wonderful demonstration, Mohan.
Close.
Let's give him a big hand. And thank you, Mohan, for giving us a wonderful...
Yep, thank you, Mohan.
Okay, so we move to Dr. Amit. Sir, you're on.
Look at that.
You're on, Dr. Madhya?
Yeah, see what I've done now. almost the whole tumor I've dissected, except for its connection to the muscle. And see what I found here. When I went ahead dissecting, I found one end of the tumor again, one more lobe of the bilobe tumor. Yes. So that is distally. So a little bit more dissection here, and then we are going to try to remove it. But this is the largest I've removed, let me tell you. I've removed a 5 centimeter one.
Dr. Amit, Pramod Shinde here.
Hi,
I believe that you are going to take away a lot of surgeries from the surgeons. You already have taken some of them away. Yeah.
But I think it's for the patient's good, no?
Yes, absolutely.
Yeah.
And why do you say he is taken away from a surgeon? He himself is a surgeon. I know, but he is doing endoscopic surgery exclusively, yeah. How about cysts that we many times find just beyond the G junction onto the fundus?
What?
Cyst tumors, similar procedure can be done inside the stomach or in fact in the duodenum also. But we do find some cysts at the fundus near the G junction.
Yes, we do find.
So,
and at the fundus, sometimes removing this cyst is not so easy. It's very difficult.
Yeah, that's why I asked, have you done any so far?
No. That is a little dangerous because you can easily create a hole in the stomach. But then what we do for these tumors is either we have to do a full thickness resection, EFTR, or then we apply an endoloop around the cyst and just ligate it, strangulate it, and then leave it inside. If you just wait for a few weeks, you will find that the cyst falls off in the stomach.
What are the
I
chances
see,
of
I see,
bleeding?
I see. No, that's a new one for me.
Yeah.
But even if there's a hole in the stomach, you are already inside the peritoneal cavity, so it may not be a big deal because you have the wonderful full thickness clips also with you.
A very good idea is to go and just ligate it, strangulate the neck and leave it. Slowly by pressure necrosis, the gist falls out.
Dr. Madhav, Dr. Chhabra here.
Yes, you know what I'm doing now, Monish? I'm trying to catch this thing and trying to go around it, and then I'm trying to pull it out so as to disconnect it from the muscle. That is provided I can catch it, but we are not having a big snare which is strong enough to catch it. That is the problem, okay?
So this part is blind?
This part is blind. So what we do normally, after we have done complete dissection all around, see normally if this leiomyoma would have been smaller, I would have gone below it with a cap and gone below it and dissected it from the muscle. But here there is no space. My cap cannot enter below the leiomyoma. So the only chance I have got is to apply a gentle traction and see.
Sometimes once you catch it, it's very difficult to open the snare.
Yeah, very difficult to
open the snare back.
Yeah.
Amit, just pulling like this, will it cause bleeding? Some of the vessels will just open.
Not remove it like what happens is, Vivek, actually bleeding, you feel that it will cause bleeding, but these vessels immediately retract. In fact, it bleeds lesser than cutting.
Yes. Okay.
Yes. Close.
I think we have caught the peduncle.
And then, after we have removed it, then what we do is we go inside. No, not coming, huh? Okay, catch this one.
Dr. Madhav, the origin of the tumor, is it a broad base or is it just a pedicle from the muscle?
No, it is not pedicle, but it is not too broad also. It is not like a villus adenoma.
So the dissection on the posterior side is usually would be complete.
Yes, unless the tumor is small and you can go posteriorly.
Okay.
In this case, I just can't go posteriorly. I tried, otherwise I would have shown you a complete dissection all around. But now here I have dissected it from all sides. Mucosa is there, left side, right side, even the bilobe at the end, that also we have dissected out. So now the only hope is catch it, yank it out.
My worry is that you are catching at the bilobe area. So it will be a piecemeal.
Small area, I think we can dissect out later.
That we can see. Even if the big one comes out.
No problem at all. So when it is piecemeal, no problem.
Normally I remove by this technique. It comes out very fast. But this one, the snare is too small for the lesion. Have you caught it? Caught? And if you have a spiked snare, that is ideal. See, it is not yet tight. You can actually see it is not tight.
Push the snare in and then tighten it.
Now tighten. Now tighten. A little better. See. You can see it sleeping. Other option is if you will cut it.
Any chance of doing a piecemeal polypectomy like a thing here?
Yeah, we can.
Amit?
Slipped. Oh, one piece has come out, Sajan. No, this piece is.
I think it is.
Let us see.
Just remove this piece.
Give me a snare, please. But let us see. If part of this has come out, then I can go below it.
That should be
because this is what was preventing me from going below it.
Yes. You have a tripod to catch it?
Huh? What?
Tripod.
Snare.
But we can see a very nice, wide, unbelievable tunnel all around. And that's a wonderful sight to watch, really.
Yeah. Catch it. I have to catch it, no? Catch.
Wonderful, wonderful. So here it is, Bill.
CO2 is going on?
Are we to use the cutting current or it was by force?
Well, just now, only by force.
Cold slowly.
What about this? Oh my God, look at this there. Okay, catch.
Now you'll catch everything.
Oh, but the snare is going towards the left, no? Right. Catch. Got it?
No, I think yes.
What happened? Huh? You can change the snare if you want. What is the situation down?
You have cut it again.
See here? We can dissect it now. Now give me a knife.
Superiorly.
Knife, IT knife. Quick. People are getting restless.
Amit, piecemeal cutting is not advised. It will cause mucosal injury.
Yeah. That is one possibility, but I can do it also. But in case I get dissected out from below, that is the most ideal thing to happen.
Sometimes this whole
Because there is such a large tumor, you don't have an option.
The mucosal entry.
You have to do a piecemeal.
Go from here.
All this attachment is only towards muscular side, is it?
Yeah, they are
not mucosal side.
Not mucosal. Mucosal part is already dissected.
We are below. And in case I can take it out from below, then it will just come out like a lollipop. I think it is too much charred. clean.
Almost at the distal end, I think. Two muscle fibers.
Pankaj,
Another knife.
Yes.
No?
can you move to the other room till you dissect the...
Yeah,
We
yeah.
are just taking the patient.
Just ask Amol if you have some other case.
Just be with us for 2 minutes. They are just shifting the patients in both the rooms.
Soft coil, yeah.
Now tumor is up.
And it's surprisingly there are no major blood vessels, no, around this. There is no bleeding.
Blood vessels will come with it at the right time. You can see one over here already.
The problem is they come at the wrong time.
Hey, more than the water, no?
In both the rooms, there are patients are being shifted, so just give 5 minutes. In the meantime, I think we can take this out.
Where is the connection? Left side.
To the left, yes.
कहाँ गया वो?
Dr. Matthew, 6 o'clock is the muscular plane, is the muscle?
Yeah, below, yes, that muscle fibers.
Yeah, what you see, no, that's the muscle.
Pankaj, you have some other case?
Yes, yes, they are taking.
You can't hear you, Pankaj.
One room, the patient is getting extubated.
You're not audible. No, something wrong with the system.
Hello?
Not
Can you hear me?
Hello, can't hear you, can't hear you.
Dr. Matthew, for a small leiomyoma, you would dissect all around the thing, because the size was big, hence that's why you...
He's not able to enter the space. There's no space for entering.
There's no space.
That's the big problem.
For what, whichever leiomyoma, you have to dissect all around. But when it is very small, no, you can actually go even below it and totally disconnect it from the muscle level.
Dr. Mishra, they are just inducing a patient in the other room.
Okay, no problem. Because Amit will be comfortable dissecting it.
Okay?
Yeah, yeah.
One more attempt now of pulling.
So Amit, if you just pull you shear the vessels.
Yeah, doesn't matter, because those sheared vessels are easier to catch and coagulate.
Okay. And what do you think will be the attachment to?
What?
The attachment will be to which part of the esophagus?
Attachment is to the muscle.
Muscle.
Muscularis propria.
Okay. So if you have read, nothing matters because you just done a poem.
What?
Even if there's a tear, then no problem. You just done a poem over here.
Yeah. It's like this, and that is inside the muscularis, inside the tunnel, no?
Yes.
One piece he has cut and removed.
You are able to see all the tips and tricks of how to snare an impossible looking specimen.
The problem is that these snares are so soft that it never goes at the place where you want it to. You need very stiff snares, you know. See what happens now, when we close the snare, the snare itself collapses on itself. Even then, the snare is like this, like a cobra.
इसको यूज कर चुका ना एक बार काटा तो मॉडल है इसका.
See what has happened to the snare? See?
It is slipping all the time. Take a new snare. I think you have used it with force, so that's it's modeling it like that.
Okay, so we'll go from the other way around. Open please, open.
Could you use another snare?
Take a new snare.
What?
Take a new snare. Since you have taken out the part, it's got remodeled into that area.
Oh, see what I've done.
Now you've got
I've
it.
done garlanding of the tumor. Let's see. Have you caught it? Check. Where is it?
No, it is slipped again.
Open please.
This is midway.
Have you caught it? Caught, no?
Yes, it seems
Now
to
you
be
can
caught.
break over here.
Yeah.
Okay. Slipped. Kasa? Kasa nahi? Pakadte bote.
Give another new snare.
No, this is the only snare we have here. There is nothing.
Amit, how about going to the distal end of the tumor and then catching it?
You know that distal end, there is not much space given. See here. It will not go beyond it.
शहजाद उसको remodel कर दो.
No, otherwise you cut it.
It is.
Cut it. We'll do piecemeal resection.
It's got a memory sort of a thing. It's become like that. Now it's okay. It's straight now.
Piecemeal resection करेंगे, हाँ?
सॉल्व हाँ कर ले बिल्कुल. So you take the plunge.
क्या? Yes, close the snare, close the snare. Oh, even if I go down, from up the snare is rotating. Have you caught it?
Yeah.
Then let's apply a little current, no? So that it goes in the tumor.
Yes, that's better. Just like polypectomy.
Which one?
Just like you do for polyps. Statutory warning is only for the brave-hearted.
Huh? What?
Statutory warning is only for the brave-hearted to do all these things.
I think it's caught.
The operator should not be wearing a pacemaker.
Slip, no? One more piece has come.
Any comments, ideas from the audience?
Clean the scope, please.
Sir, can you change the position to get to the base of that particular polyp?
Which one?
Can you change the position of the patient so that you can go to the base of the polyp?
No. It will not help, Vivek.
Go ahead, please.
Pani Mara, please.
So that is what he does. He catches the distal edge and then he pulls it. I know, he can't do it.
So distal edge, Dr. Madhu?
Yeah?
Purohit here.
Who?
Dr. Purohit.
Hi.
The distal end or the distal edge of the polyp is still free or is still attached?
Little bit attached. Actually, even this one is little bit attached.
Yeah, because that is where your snare cannot go round, the distal one. If it gets round,
That is what he's trying to pull.
Yeah.
What we are going to do is we are trying to yank it out. You know what I mean, no?
But then
So we are going to disconnect the attachment with the muscle only by pressure, only by pull, by traction.
But you can pull properly till unless you get around the distal part. It slips.
Give a slow, continuous traction rather than twist and
No, it comes in one stroke.
I think the only option is to do a piecemeal and reach the lower area.
I think one piece has come out. Nothing has come out.
Yes. Allowed down this portion is come out. Just lift it
Sir, could you track your tail, na to? Come, let's take it out. Okay, let's first go in and see what has happened. is because of the piecemeal cutting that there is little bleeding. Otherwise, normally this is a bloodless procedure. So what do you want to do now? You have to take a final call. Snares are not working. So either we keep on cutting it and remove it piecemeal, or you have to just keep on dissecting. Then I will not join you for dinner. But I'll remove it and come.
Can the snare be passed from below upwards rather than from up to downwards?
What? Okay.
Instead of opening the snare anteriorly and then going behind the tumor, can the snare be opened behind the tumor and pushed anteriorly?
Have you caught it or no? Catch it.
It is caught.
Right?
It's really over.
Come out? Yes.
There is a piece coming out.
He's using it.
Big
piece which has come.
He's using it.
It's not coming out of the mouth now. See?
Crush it.
Wait.
Mouth का बता लो.
Hey, it has come.
आ गया.
It is not just mouthpiece.
Mouth का बता लो.
Yeah.
Out.
Big piece has come out.
Big chunk.
Open the snare.
So again, this is piecemeal. The whole thing has not come out.
Just keep it down.
Just show them.
Take the snare back.
I think the whole thing has come out.
You can see a stalk there.
Yeah, you can see that second lobe also. Wonderful.
Agreed?
Let's go inside and see what's there.
But now we have to achieve hemostasis and see the rent in the muscle.
Yes. Oh, you say rent in the muscle?
There were a lot of questions about that, no? Oh, there's a tumor here also.
There's a place that will be there also, no? Is there residue left?
See this bleeding?
No, not much.
Not much, you say.
Not much. Thankfully.
Can you see the whole leiomyoma is out?
Yes, we can see that now.
So let's clean it now.
Yeah.
See this, empty.
Very good.
Really great.
Big round of applause for Dr. Amit Mahapur.
So I think this is the largest one I've removed, 5.5 centimeters.
So it is just like Sachin Tendulkar saying I have scored 200 twice and I have scored 201 now. 5.5, the last was 5 centimeters. 10% more.
See, this is the rent in the muscle. Can you see that?
Yeah, we can see the rent there on the left side.
But because of the submucosal flap, the mucosal flap,
this is the rent.
It doesn't cause a leak. And surprisingly, you must have seen that the vessels don't bleed so much after pulling it out.
It's just a generalized.
That is because Amit Mahapur is doing this.
No, this is a routine thing. So I think the advocated practice is dissect it all round and just yank it out.
Wonderful. And now you only close the mucosal.
I am first doing hemostasis, perfect hemostasis. And then close the mucosa like poem. But a big thoracotomy is saved. Open. You should always take a small
A thoracoscopic resection is saved, I will say.
Yeah.
Okay, open. Catch. Open. Advika. Open. It is below. The forceps has to be opposite direction. And you need a small forceps for smaller regions. Catch.
This is a soft cord that you are using?
Yes.
Soft cord.
Yeah.
Open.
Soft cord has less depth penetration, I believe. That's why that's the current of choice.
Open.
Yeah, it coagulates less in depth and coagulates slowly, so you have a better hemostasis.
Yes.
When you use force, it tends to cut also along with it. Yeah. Okay, now we can shift to the other room.
Okay, thank you.
Yeah, thank you so much.
Great, Amit. It was a very difficult case.
Hello.
Yes.
Can you hear me, sir?
Sure.
Now we are shifting to OT5 to Dr. Rupa Madam. This is a case, a 51-year male who presented with symptoms of anemia and gastric outlet obstruction, partial, it's not a complete gastric outlet obstruction, but partial symptoms were there. On evaluation, he had ocal blood in stool, iron deficiency anemia and hyperproteinemia. On gastroscopy, there were multiple hyperplastic polyps of varying size in entire stomach. They were larger in the distal part, in the antrum and in the duodenal bulb. A colonoscopy was normal. There was no family history of polyposis syndrome. He also got done a PET CT outside that was suggestive of thickening in gastric wall in the distal part and proximal duodenum. It was not suggestive of any malignancy. Plan is to do NBI and discuss. Over to Dr. Rupa ma'am.
Rupa, you are on.
Yeah, can you hear me?
Yes, we can hear you.
So after all that third space endoscopy, we are into second space again, and I'm in the duodenum. So what we'll do is, this duodenum looks pretty neat, and I won't show you right now what we saw in the stomach. And we switch on to NBI just to show you that there is some amount of villous flattening here. So these are simple things which the NBI can sometimes pick up, and you can see very well that there is this. So this is the villi, and if you go in for near zoom actually, then you can also see within the intravillous loops the papillaries. So you can actually have a very clear picture of what is happening in the duodenum. So we slowly come out from the duodenum, and here the problem starts. So white light first, and
there was another lesion deep in duodenum.
Deep in duodenum, it's a small one. We have more exciting things to see.
What are these? Hyperplastic polyps?
Yeah. So these are all hyperplastic polyps, and if you go closer, there is some amount of lymphangiectasia, and that is what is showing as white on NBI.
Dr. Rupa, what we can see is a white opaque substance which is classical of adenoma, not of hyperplastic polyps.
No, white opaque substance is not like this. The picture is different, and it will be on the margins. So now when we come to the stomach, you will see.
Can you switch off the near focus?
Yeah.
Thank you.
So look, this is the picture. So this is the whole
Can you please be a bit louder, Dr. Rupa? We can't hear you.
I'm having problems with the mic today somehow. Can you hear me, Dr. SP now?
Yeah, it's better. I can hear you now. Good.
Yeah. So
They are afraid to touch you, even the mic.
no, but, yeah. So this is better. So as you see here, there are lots of polyps. They're just absolutely studded. And again, actually, I'm not used to these knobs. Yeah.
It looks like you're going mountaineering.
So I'm just switching over to NBI to see what we can see here. Now, first thing to see is this area, the demarcation zone between the normal and abnormal. And here, this is a very classical of a hyperplastic polyp. I'll freeze it for you. So you see the normal area here, and then when you come nearer, here is the polyp with a regular pit pattern, and that's the beginning. Over gradually, so we don't use the Kudo's classification here, we just look for regularity of pits and and for the surface pattern. Now you see here again. So if you see here, is it clear in the hall there?
Yeah, you can see.
Yeah. So what we are going to look when there is...
Can we wash the lesion and then you can show, please?
I have been actually, there is a lot of mucus, but there is, though they said it was intestinal obstruction, we could enter the duodenum quite easily. Is this better?
Yeah, this is better.
If you put in more water, it will zoom by itself. Just use water magnification.
So I have over here Professor Abe and Dr. Prasad. Your comments on this?
Yes, can you hear me? So actually, I never seen this kind of the region, but there is no material food and material fluid, and you can easily advance endoscopy to the duodenum. So this, I think that these regions look like the hyperplastic pipe. So personally, I think that we don't have to remove the polyp at all. But I just have more ESG recommendation. Could you explain?
So I was talking about a different kind of polyp, the isolated prepyloric hyperplastic polyp. The ASGE actually recommends resection of these polyps if they are larger than 2 centimeters for 2 reasons. One, they can prolapse across the pylorus and cause anemia, and they can cause obstruction, but also they can get adenomatous changes, and they are considered precancerous, although they are hyperplastic. But we're talking about an isolated polyp that can be resected. Here it's kind of a diffuse process. So one thing we can do here, if the patient has gastric outlet obstruction, then we can do kind of a palliative EMR around the pylorus to open up the pylorus. But here, the patient looks like she's asymptomatic. So I don't see that we're benefiting the patient by doing a resection.
Dr. Mohan, for the interest of the audience, how do you label it as a hyperplastic polyp? What are the features here?
So I'll leave this to the...
We can't hear you, Dr. Mohan.
In Japan, we sometimes experience a large hyperplastic polyp. The adenomatous component of adenocarcinoma was included, but our experience is only the solitary polyp. I never seen the hyperplastic polyposis. I'm not sure about that.
This is hyperplastic because of 2 things. One is that the pit patterns are more or less regular throughout. You can see some fronds, which is also seen in hyperplastic, and commonly if you see the area where there is normal mucosa, this area you can see clearly the margins are very, very defined. Now in such a situation, what we need to do, as Dr. Mohan just pointed out, is there any dysplasia, or where should we target biopsies from? So normally in such a situation, what we should do is, we should target from the bigger polyp, the more friable, and in any, if we find any abnormal vasculature.
At places there is some villous pattern. Could it be some adenomatous change occurring here?
So those are the areas where you will target the biopsy from. So there is some fronding, like see like a villous fronding here, if you see. So these are the areas where you can take a biopsy from. But
what are those whitish structures which you see?
Those are the openings of the pits. They are a little thickened. So that's why they are looking like white, thick structures.
How would you record this for the purpose of follow-up on some kind of a recording system, apart from the video that we have? But when we have to follow these patients for years together, is there any physical method, any paper method, any particular method?
But the best thing to do is, when you are taking biopsy, take the picture and mark it immediately after taking the biopsy. The location and where you took the biopsy from, and a picture. So this is, again, in Japan they do it very routinely. For us it doesn't sound very, possible.
The patient is hyperproteinemic? That was there in the history.
Yeah.
Can there be hematomas and truncated Canada or something like that?
Yeah, so the things to see here is like this. See, wherever there is a polyp and the normal area, you see this, so this is just studded with multiple sessile polyps. I wouldn't recommend, I don't think unless there is symptomatic obstruction, there is any help in removal. However, the large polyps, if they are causing obstruction or it's located in the antrum, which can, potentially cause future problems, we can.
If the patient has anemia and even if there is no dysplasia, what is the management?
Could you repeat the question, please?
If there is no anemia, if there is no dysplasia, what would be the management?
There is a hyperlipidemia and there is anemia, and even if there is no dysplasia, how are you going to manage?
So if you feel that your patient is, this is significant, but I still wouldn't recommend removal of these.
I think there are so many that removal is impossible as it seems from the endoscopic
I think treating the anemia by removing the polyp is not the answer in this case, because fecal occult blood test should be done in a very strict manner. Then you will say yes, they are the source of bleeding. The source of iron deficiency anemia may be many things. So I think it is better to leave it alone.
This patient is definitely made a small bowel evaluation, a careful capsule endoscopy, an endoscopy, though the duodenum looked relatively free. So a full examination.
Where are you? You are there.
So what would you do, Dr. Monish?
I think if the patient is hypoproteinemic, anemic, the total gastrectomy is the answer. Because you'll have to put this patient on surveillance. There are so many of them. So I don't know what.
But they are hyperplastic, Dr. Monish. They are hyperplastics. Total gastrectomy. What is the age and is he bald?
It's a 50.
This patient has adrenal lesions also. Will you do that intestinal transplant? That mean?
No, basically, unless the small bowel is carefully evaluated and if we are sure that the lesions are only restricted to the stomach, then it will also depend upon if we have to first treat this patient conservatively, if we are able to manage the nutrition, the hyperproteinemia, and keep up the acceptable quality of life for this patient, then the treatment would be conservative, because radical gastrectomy itself is a major procedure. It is again open for malabsorption, and the quality of life issue can come even after total gastrectomy. So decision for a total gastrectomy will have to be very, very closely and very carefully weighed in vis-a-vis the management and the quality of life issues.
Can I ask a question, please? Dr. Vikram here at this side. Rupa, can we consider intestinal gastric atrophy with a nodular type of intestinal metaplasia here?
No, intestinal metaplasia, the blue crest is not there at all.
No, blue crest is not there, but multifocal nodular, because the mucosa in between looks...
can we see the normal mucosa if it's nodular?
Because that explains the anemia of the patient. If you see the...
Can we see the normal mucosa somewhere?
Yeah, here is the
Here you can see the normal mucosa.
So there is no gastric atrophy here.
No, there may not be gastric atrophy here, but it can be multifocal. So some islands of residual mucosa may be left.
I think, see, there will be islands of residual mucosa which is normal. This is a case which is studded with things.
Yeah, we can see the collecting veins and...
Yes, but what...
So just see the central area. I focus on
myeloblastic anemia there. Here hyperproteinemia is profound, I believe. No, then what are these lesions? So many of them. They are is the patient bald? They are all hyperplastic polyps?
So this could be a conchoid Canada syndrome.
Conchoid Canada syndrome, that's what you are hinting to.
Yeah, we were just discussing that here. And I think
baldness and nail changes are very important in that.
Yeah, so if there is gastric atrophy, we normally wouldn't...
Look at this mucosa right in front of you at this point. Here.
Just a second, I'm just...
Exactly, here. That's the area I was... this right in front of you.
I'm sorry, I'm just trying to clean the lens.
Right, please.
Just push them. Yeah, you can. So for this patient, before we switch to the other room,
Rupert, does the presence of colonic polyps too?
we will have to look for colon, we will have to look,
No colonic polyp.
we will have to look the entire small bowel. We should not go for gastrectomy unless the patient is...
What does this mucosa suggest to you, which is in front of you? If you can...
I actually cannot see the mucosa.
Right, there's something on your lens.
Colonoscopy was normal. Colonoscopy was normal.
Now just look at this.
What happens is there are hematomas, hypoproteinemia, baldness, nail changes, and there are
This is a small round mucosal pattern. This change a normal gastric epithelium.
So the regular mucosa is normal.
No areas of patchy atrophy in between.
No, these are all normal, Dr. Manish. There is just division between the polyps. We can actually see the regular microvascular network also. The larger polyps with friability, take a biopsy, keep a close follow-up. And to summarize this patient, we will have to keep a close follow-up and surveillance. Right now, there is no obvious obstruction. And I
Did you do H. pylori testing on this patient?
It was
I
positive.
wouldn't.
It was positive. And he has been treated for that.
Okay.
So that would be the lesson for this, that targeted biopsies may be possible and keep a close surveillance, no obstruction right now, so there is no need for any bypass or any polyp removal for obstruction. Is that okay?
Since we are here where all the leaders in the endoscopy and the third space endoscopy are there, I believe that we must also start looking at our record systems. Like the Japanese have a very detailed division of the stomach into various areas. If we are to keep an NBI surveillance on these kind of patients, maybe we should have different kind of physical records for these patients, and maybe we can look at the way we are recording, because our record systems for a routine procedure may not be sufficient for these kind of patients. Yeah.
Well, Dr. Mishra? Hello?
Yes, Anil.
Yes, sir. So I think that was a very interesting discussion on NBI for these lesions. Now we are here back again with a patient with Acalasia, and I think Mahesh or Ravindra will give the history.
This is a 34-year female. She is known case of Acalasia cardia, underwent left Haller's myotomy 5 years ago. Now she has presented with recurrence of symptoms of dysphagia and chest pain. On manometry, she had type 2 Acalasia, and as you can see over here, barium swallow was suggestive of Acalasia cardia. And there has been some marking which sir will be explaining during his procedure. Over to Dr. Amol.
Can I ask something before we begin? This manometry is the recent one after the Haller's myotomy has been done. Was there a manometry done before the Haller's
No idea, because this patient presented to us only with a recurrent Acalasia. The previous Haller was done elsewhere, and there is not much of details. There was only a barium, I believe, which had been done at that time.
So, this was abdominal Haller's or a thoracic Haller's?
It was a laparoscopic Haller, so I believe it was not a thoracoscopic.
We will go posterior on the
Yeah, so we'll do a posterior myotomy. Now I am at the G junction, and this is at 39 centimeters. Mohan is here with me, and the marking which is strong on barium
looks very patulous.
Yeah, it is patulous, but the manometry did show resistance and the pressures were high. So that is what actually.
What about the propulsive action? The body propulsive action was there?
No, there is no body propulsive action. But this typically can happen after a post-dilatation or a post-Haller situation, where it's not as
Can we do a dilatation once and see does patient shows improvement? Then doing the Acalasia, maybe, I think, I have a very less experience. Mohan is there, you are there, many people are there. Doing the poem now or doing the dilatation, see the response. If patient respond to the dilatation, you have a point. The manometry finding, are we treating the manometry finding or the endoscopy which is showing that the G junction is patulous, there is no resistance. So what is the opinion, Mohan?
We should see why the patient is symptomatic now. As you see, if you do a balloon dilatation, you will treat only the LES.
Not only that, Mohan, this since it is very tortuous, Dr. Puri, what will you achieve by doing a dilation?
So dilation,
I'm talking about poem. No. Doing the poem at this stage is justifiable.
No, Rajesh, see, the main thing is, let's not just go by the manometry findings. See, manometry is showing high pressure zone at the LES. The barium is also showing a hold up, and the patient has symptoms of dysphagia. All three things have to be taken into consideration. And it's not just barium, but we normally do a fluoroscopy and we would observe the barium passage ourselves, and we would do a timed barium in the situation. And if there is barium hold up at the end of 5 minutes, then probably this patient definitely needs will benefit by what I would say is a LES pressure reducing procedure. May it be a dilatation or a poem, or even a repeat lab Heller.
Could you just take your microphone a bit off from your mouth, please?
Okay.
Yes.
Okay.
That should be better.
Okay. Right. What do you think, Mohan?
So I think patient needs some therapy, and because the patient is symptomatic and the barium is showing hold up, he needs some therapy. Now,
Yeah, same thing I'm saying, the dilatation is easier.
That's what we are saying, that if you do dilatation, you will act only on LES, which may not be may not be complete therapy for this. There can be a hold up because of lower esophageal contractions and etc. So as you see, there is a LES is totally lax, and there is some reflux also, reflux esophagitis. So that means it requires to be, the myotomy needs to be extended into the esophagus also, which may not be achieved by a balloon dilatation.
Yeah, I personally also feel that if the dysphagia would have come up early, post-operatively, then dilatation could have been one option, but this is already 5 years after lap Heller's myotomy.
Right, and
so therefore maybe a poem could be the answer.
Yeah. And we need to consider the patient's, psyche as well. She's already undergone a Heller's. Now again to subject her to a dilatation, and which again may not be a permanent procedure, and poem definitely has a better chance of giving a permanent solution to her. So at that time, to reserve a permanent procedure as a third procedure, I would be reluctant to do that. So, okay. So what I'm going to show over here, and Mahesh will put up the paper. See, the reason why you saw that marking on the barium is, see, one of the challenges when someone starts poem is that when you go through the tunnel, it might be difficult for you to reach and identify the LES or the G junction. And Mohan in his presentation this morning also has mentioned how the various methods, how to identify the G junction. We actually have been working on this formula for some time, and we've got a follow-up of about data of about 26 patients now. Now this is a simple equation called as X is equal to Y plus CZ, where Y stands for the LES or the G junction on the endoscopy view. So what I am measuring just now, this is at 39.
So Y is 39. So
Y is 39.
X is the G junction in the tunnel, where you cannot see. You want to calculate the G junction, you will encounter in the tunnel.
Yes, so X is the variable which you want to find out.
So Y is known. Y is known because we are in the lumen and we are able to see where we are at the G junction. So that is 39 in this patient.
Yeah.
So what is C and what is Z amol?
Yeah.
So we know amol as an endoscopist. Now we are seeing amol as a mathematician. So he will be teaching us now what is C, what is Z.
Actually, Mohan, sorry to say, but I am very bad at mathematics. This formula, after I gave the concept, but the formula was designed by my son, who is in medical college, but he's the mathematician behind this. He's standing here, Jay. So, and Mahesh and Nachikeet have been working on this. So we got this paper in, the poster abstract in DDW now. Now Z, what I would like to point out is, Z is the widest diameter of the esophagus on a barium swallow.
Okay.
So at the widest point.
So in other words, the esophagus is wide, then you may find that D junction more deeper.
Yes. So the difference, the disparity will be more between the Y and Z. If Z is wider, then the disparity between Y and Z will be more. Okay. And how do we find that out? We find that out by the C, which is a constant. Now how did we derive this constant? We derive the constant by calculating prospectively, and consecutively in our previous patients with poem.
we calculated the X, Y and Z and we derived the C from that. And after deriving the C from that, we are using this as a prospective method. So currently we are doing a blind study. I calculate the G junction and tell them, and they calculate the barium diameter, they will calculate and they put it in the computer and they don't tell me that. And once I reach the G junction through the tunnel, I see the palisading. The palisading is the endpoint that we are looking at. Once I reach the palisading, I tell them, okay, this is where we are, and then we compare. And we found a 99, practically a 99% correlation. So let's see if we can find that now today. So according to this calculation, yeah.
That may be true for virgin patient, de novo patient, but this patient has already undergone a Hellers.
We've tried it on both recurrent and these patients both. Unless only for sigmoid patients probably the variance is a little bit more, because there we have to take into consideration the lateral migration of the esophagus from the midline. And that too in a very widely dilated sigmoid esophagus where there is also axis deviation. But otherwise in most cases we found a variance of less than 1 centimeter.
Dr. Anil?
Yeah.
So this 41 means you go endoscopically up to 41 centimeter?
No, through the tunnel I will go up to 41 centimeters.
That is
I will anticipate that at 41 centimeters I will start seeing palisading. And that's where I cross the G junction. That is what I will estimate. And then I will come out and we will check it.
Okay.
So I am starting my injection at about 29 centimeters.
We don't see endoscopy images, please.
You're not getting an endoscopy image?
Dr. Anil, can I ask you something?
Yeah, sure.
Now, your manometry picture that was there, that on the background did not show any much of peristalsis to see it, and it has been classified as type 2, and plus this is the problem. Poem after a Hill's myotomy. So would your length of myotomy through the brain be the same like you do for all patients, or will it be longer or shorter or anything different?
See, this is a type 2 Acalasia, so we would do a 6 to 8 centimeter myotomy, because let us not consider and let us not bias ourselves by what has been done in the past. Presently, the current manometry definitely shows that it's a type 2 Acalasia, so I think it merits a 6 to 8 centimeter myotomy.
And Amol, how have you prognosticated the patient? What will be the result of your myotomy?
It's a type 2, so that should be, that way, from a type 2 point of view, the type 2 response.
The patient would be a bit skeptical because he or she has undergone Hellers and has the symptoms again.
Yeah. So we definitely tell them the type 2 has the best results after any therapy for Acalasia.
What Dr. Shinde says, there's hardly any peristalsis in the body of the esophagus.
Yeah, but there is pressurization. So if there is pressurization, that means there is a potential for peristalsis.
So Dr. Amol?
Yeah.
What differences you find after the myotomy while you going inside?
Okay. Rajesh, what I will do is, I will just show you this technique which I learned from Mohan. We use the needle knife and IT knife technique for entry, and of course Mohan uses it anteriorly, I use it posteriorly. This gives a very clean cut. So what I do is, I do a small incision over here. Okay. And now I use an IT knife.
So with the same knife, with the same injector, you have done an incision?
No.
He has created a window.
I have created a window where I can fix the IT knife.
Okay. No, the previous operators used the...
The purpose is to prevent the damage to the deeper structure?
Yes.
Yes.
Okay. Is more safer actually.
Yeah, for the beginners. But if you have good
The knife can be hooked at, inside the incision in the mucosa, I believe.
And somehow I prefer to use the endocut. I am not very much fan of spray coag mode.
Mohan, what do you have to say about that?
See, the difference between spray cog and endocut is very simple. Endocut is a technique where you will get a clean cut, while spray coagulation is a powerful current. It is more of coagulation. So if you coagulate, you have, it is a very quick also. So if you want to do a quick thing, you do a spray coagulation. It is like APC, it's a non-contact, and you just have to put the blade in front of stretched fiber and just put a pedal and it will blast. So and the bleeding will be less. While endocut, you have to touch each and every fiber to get the cut. But if there is a spot like this, then there will be a ooze. But you have to be very, very careful about the vessels. If there is a small vessel, you go to either soft coagulation or a forced coagulation to stop it. So endocut is more cleaner, more slower. Spray coagulation is more faster, but sometimes it is messy.
So what should be done, spray or endo in this situation while doing the first step?
It is all up to you how you are trained.
Preference of the operator.
Both are same, I think. What we have found is once we were using spray coagulation more, that was more peritoneal or emphysema or more, because it is more powerful current and it was destroying some of the muscular structures also. But endocut is associated with less amount of emphysema. So they are all part and parcel. So I don't think capnoperitoneum or a subcutaneous emphysema is a complication of this procedure. It is in parts and part and parcel, and you may be seeing into 20 to 30% of cases, howsoever careful you may be.
There is a question about what scope are you using? Is it therapeutic?
I'm using the Olympus HQ190, the standard, the high definition HQ190.
190.
Yeah. You can also use the H190 without the magnification.
Has somebody used NBI in this?
Why NBI?
I don't know.
No, I don't think anybody uses NBI for...
You can see the vessels better, I believe.
Yeah, nobody has used NBI. Vision darker. So I think NBI has got no role as far as present scenario is concerned, but let us see if they have a brighter NBI and then
searching for a vessel.
Mesh of fiber, you can see the vessel better. That may be having some.
Incision, we might need to extend a little bit more there. Right. Now I have switched over to the TT knife. There's too much of fluid. Now that's one of the downsides of posterior myotomy, because fluid tends to peel and you need to suck it out more often.
And also the blade drowns in the water and it won't work.
You just use a little bit of injection because the the elevation has gone down a little bit, so what I will do is I will elevate, because then that will make the entry much easier.
So have you used other viscous solution?
For poem, no. I have not used viscous. For ESD I routinely use gelofuscin, because I prefer the elevation to last for a longer time. But for poem I don't think it's required, because it's only the entry that you need, and that is pretty fast. So after that you don't actually need it too much.
We found useful for initial procedures, because at that time we were worried about many things. But as you gain experience after 15 cases, you may not require any hyper viscous solution.
So you saw just injection made my entry into the tunnel so easy. So if your elevation has gone down, just injection will help you, and you need good elevation to be able to enter into the tunnel.
And also you see the difference between Moin's technique and Amol's technique. He is going posteriorly, so whole of the muscle is on at 6 o'clock position, and you can already see the transverse fiber running over there. And look at the dissection direction. He is pointing the blade towards 6 o'clock position, while Moin was pointing towards 12 o'clock position. So it is always the muscle which needs to be directed upon, because even you hit the muscle, you will damage the muscle, but damage to muscle is not perforation. It is the mucosal damage which is perforation. So you have to move away from the mucosa. So that is exactly what Amol is doing.
And can we forcefully force the scope? There is a sling of some mucosa is on the upper part of the cap. Can we forcefully introduce our scope or not?
So there are two problems with that. One is you may enlarge the mucosal entry side inadvertently, so that you are cutting the mucosa along with the submucosal dissection. And second thing is you may damage the vessels around that. So in that situation you may create the bleed is not that significant hemodynamically, but it spoils the planes. So that is the two things which prevent us from forcibly pushing the scope. It is better to dissect each and every fiber rather than force the scope forcibly down.
Yeah. Now that's very important. One should not force, but you should dissect your way through. That is a much better way of entry, because sometimes in fact show his right hand, please. Show his right hand. Focus on the scope. Show his right. Focus the right hand. That is important.
Amol, tell us the tricks of entering into submucosa.
See, I already told you one, that injection should be proper, so that the distal margin of your incision, it should be higher or more elevated than the scope. Then the scope will find that you will be able to get the scope in a straight line inside the tunnel. But if it is flat, then you have to dip down. And especially for a posterior entry, you must understand that your gastroscope has a limited down wheel movement. The up wheel is much more. So there is a little bit of difference when you do an anterior myotomy versus a posterior myotomy when we are talking about the entry.
Well, we can see a beautiful tunnel being created, and a large part of it looks to be because of the injection, and the current that you are using is very, very tiny bursts of current.
Yes. Yeah, see, although I am using endocut, if I don't think you will be able to focus on but what I do is I use tap of current. I just tap my foot.
Basically it's a cut.
Yeah, so I am using, majority of it is cut. I am not using the core function of the endocut at all.
Mohan.
Yes.
Can you only use the water to dissect? Then if you only use water, there will be no perforation the mucosa.
Yeah, but
water will make it at a very high speed.
There are some reports of some gel, I think whether they reported a gel which will dissect through that and create a space. Water won't create a space. It will seep through the fibers, but fiber will still remain. So our aim is to create a space, empty space.
Any method of not using the IT knife or some
people have used balloons, like pass a guide wire or pass through the scope balloons and start dilating bit by bit. David Carlock used that technique, I think.
But then you prevent any mucosal damage.
But that, we encounter so many vessels while we are going down.
Once you encounter a vessel, then coag them, then with the gastric
also. The depth, when the balloon is in the depth, when you inflate it, it may smear those vessels. But the bleeding is never a problem at all. But it spoils the planes, You cannot differentiate between muscle and the mucosa for some time, or then it is not important. That is the more important aspect rather than massive hemodynamically important bleed. It never occurs.
But hematoma has formed after the
yes. That also can be, because as Amit when he was doing, he told us that if you remove the tumor, these vessels they get recoiled and stop bleeding themselves. So the bleeding is never a hemodynamically important bleed. It is the plane which gets destroyed.
Painful hematoma have occurred after prone procedure.
There are very rare cases where they had to go again. I think 1 or 2 cases in 5,000 to 6,000 cases. So that is very, very rare. So we have to take in account whether the patient was on antiplatelets, anticoagulants. There are many things.
But I think we've done quite a few patients now who have been on aspirin, clopidogrel, and in fact some patients even who have been on warfarin and stuff like that after stopping warfarin and Clexane. So they have, but at least touch wood, so far we haven't had a clinically significant bleed and we've never had to go in again. What about you, Mohan? You've got, so far at least never, fortunately, touch wood.
Well, yeah. Now, while making tunnel, how you are sure that you are in the right track, especially if there is a sigmoid esophagus? So what is the...
Basically, you need to follow the circular muscle fibers, and the circular muscle fibers you can see over here, you have to remain parallel to the perpendicular to the circular muscle fibers. So you can see that the direction of the incision is going perpendicular to the circular muscle fibers, and then the tunnel has to be perpendicular, then don't have a problem.
Well, can you use endoscopic scissors? Pardon?
I'll just stand here again. Yeah?
Can you use endoscopic scissors to separate the strands or cut the strands?
Scissors? I am not aware of any scissors.
We have reported one scissors was Zenkas diverticulum. That is not available in India actually. We got it from Japan, and thereafter we did not get that knife. So we used in Zenkas, because in Zenkas the bridge stands out and you can catch the both ends and then you cut it. It was very easy, but we have never tried scissors in this.
Let's see. Tomorrow we've got a patient for Zenkers, but unfortunately I don't have scissors. Otherwise we would have.
That's known as stag beetle knife, SB knife, stag beetle knife, not available in India.
Anil, we can see you torquing your scope even beyond 180 degree to almost 270 degrees.
Yeah, it's something.
That is why I was wanting to show the hands.
Once I am inside the tunnel, you can see that I am keeping the direction vertical, because it's always easier to use your up and down wheel. So although my entry is posterior, very often my myotomy, it goes to more to about 4 o'clock or so. That is in the tunnel, because this is what I thought we've tried doing now. Meaning, you get into the tunnel, but then later on, because the up-down wheel is so easy to use with the torque, normally I will maintain this kind of a position for. And you can see that these vessels, we can coagulate them off. Maybe we'll need a little bit of injection now. So we are at around 38 centimeters. I still cannot see any, but it's getting a little bit tighter, but not too much. And Mohan is here to see whether our formula is working or not, and he is critically keeping a watch on the scope distance, trying to say.
Anil, I would like to say that most lap healers, cardiomyotomy surgeons would go for about 5 centimeters on the esophagus minimum and 1.5 centimeters on the gastric side. So already a myotomy of 5 centimeters minimum, 5 to 6 centimeters may have been done on the esophagus.
Yes, possible.
And we are also going to restrict your myotomy to about 6 to 7 centimeters. So since this is a redo case, shouldn't it be slightly more than what may have been done in Hellas?
See, we are going to be doing about, the total length of the myotomy is going to be about 8 or 9 centimeters. That's what is going to be happening. Because we are going to be doing about 6 to 7 centimeters on the esophageal side and at least 2 centimeters on the gastric side, maybe even 3. So it's going to be that, 8 or 9 centimeters.
Do you do any intra-procedure manometry to check whether the pressures have dropped?
Yes, we've done intraoperative manometry on occasions, initially, during our initial, in fact, one of our workshops also last time we demonstrated the use of intraoperative manometry. It's quite, it works very well.
No, especially for these redo cases, because this patient has already undergone one procedure, that's why I was saying. Would that be advisable, since the patient is post-Hellas and already come with a recurrence?
It could be done. If we are not sure of whether we've gone across, then probably we could.
I think better technology would be endoflip to see.
Yeah.
Endoflip is a technology where we see distensibility from one particular pressure, how much balloon you are able to distend. Like suppose if there is a constriction, so the same distension of balloon will require lot of pressure. While once the myotomy is complete, the same distension can be achieved by a low amount of pressure. So endoflip is a technology which can be better used in this situation rather than manometry itself.
Okay, there's a little bit of use.
About this
that if you reduce the pressure below 10 after doing a myotomy, then chance of recurrence are less.
Among there are scissors with cauteries. It's available with Siley and also from the Olympus.
So do you use it for creating a tunnel, or is it
Olympus? I've never seen it from Olympus actually.
Are they endoscopic accessories or laparoscopic accessories?
Endoscopic from I think you dissect but the thing is you don't cut, you dissect over here. So you're dissecting separating the fibers, not cut.
Yeah. So
but for cutting the muscles, I think that not an issue.
An endoscopic scissor with cautery would be useful even for ESD. So we're not talking about just poem. It could also be an option to be considered for ESD.
Yeah, Amul Mohan Prasad here. The Olympus scissor was available for almost 25 years. So I had it even before 20 years. And then the Shaili scissors has got an additional cautery.
Okay. Unfortunately, I have never used the Shaili scissors, so I have not even seen it.
The Olympus scissor without cautery has been there for almost 25 years.
Yeah, but that is without cautery. I have seen the one without cautery. So
yes, Shaili,
I'm not aware of one with cautery. So
yeah, I made Shaili develop that product about 15 years back with cautery.
So Amol, in your entire procedure, there is no injury to muscle. Any trick?
Go step by step. Take your time. That's the only thing. And dissect fiber by fiber.
Very clean cut. Very clean dissection.
He is a surgeon, by the way.
He has done the husband disease also.
Yeah, we will be talking about that tomorrow morning. What I need to present. I've taken the liberty to, change the topic of my talk.
Okay.
The lecture on various modes of the electrocurrents is absolutely relevant in today's day and age, because the power sources have really progressed to a great variety. I mean, different people are using spray current and then force coag and then endocut Q. How do you compare this?
I think it's a matter of choice and it's a matter of how you get trained. Each has its own advantages and disadvantages. Now you saw that there was a little bit of bleeding over here. That would not have occurred if I was using spray coag, right Mom?
Yes.
No, but here I have to go there and coagulate that. So it takes a little bit more time, but then the dissection is a bit cleaner. So, it's what you want. Finally, it's a choice which you need to. We are approaching the LES and G junction definitely because it's getting tighter. You can see that the mucosa is, a little bit tight over there. And now, where do you want to inject? We need to show you that.
We would also like to know the tricks of knowing when you are approaching the G junction.
Here you
are talking about the palisading, and
here you can
elaborate on this.
There are two different colors you can see there, and Amol has just placed the cannula above the muscle margin. So that means that he will not inject into the muscle. Water will find its own the least path of resistance, and it will be submucosal fibers only. So that was the trick here, to keep your cannula just above the muscle fiber.
It's important to remain just above the muscle, meaning because even in a submucosa you can be deeper or more superficial, but if you are too superficial, then you are going to leave a lot of submucosa behind adherent to the muscle, and that makes your dissection a little bit, you don't get the plane so well. But if you are exactly on top of the muscle, it gives you a better vision.
Mohan, any follow-up of the Mumbai case you assisted?
He is fine now.
Oh, okay, good. Very well done by you.
It's a bit getting a little bit adherent over here. I think it's a bit fibrotic because the muscle. Yeah, but this is likely to be because of the previous surgery also. And they've added a fundoplication at that time, no? So there's going to be some amount of fibrosis. Good. Here you can see I went a little bit into the muscle over there, but then...
Do you know what fundoplication was done in this patient? Was it anterior or posterior?
Actually, there are no details available, but very often we are going to be getting patients like this. So that's again the teaching point.
Because in lap halos, most of the times posterior dissection is not really done so much, you know.
Yes.
It's only the anterolateral dissections.
Very difficult to reach the posterior area. Very difficult to reach that area, posterior.
Posterior dissection is not supposed to be done in a lap halos myotomy unless you are planning a Toupet's fundoplication or a Nissen's fundoplication. Most of the surgeons would do a simple doors, which is an anterior fundoplication.
Approach to the thoracic root, then they can approach that area.
But thoracic root is not very popular in India, and most of the surgeons would do it laparoscopically.
So here the finding direction is important. You can see there is a lot of twisting which is occurring, and whatever is from 12 to 9 is mucosa, while all the muscle fibers are lying from 12 to 6 o'clock position.
Yeah, this is because I turned the scope around, because sometimes you need to turn the scope around.
The problem is he is turning the clock all the way around.
Yeah.
So what should be done in this situation? Almost 360 degrees.
So for Amol it's not mattering what, even for Amit it is not mattering where the 12 o'clock is. They were just looking at the muscle fibers and cutting out.
Yeah, sir. See, finally because your scope does move within the tunnel and you have to torque it to get the right direction, because otherwise what happens is you can't get the knife at the right place sometimes. Now, especially if there is a tortuous esophagus.
So now it's at 11 o'clock, the muscle is at 11 o'clock now.
So muscle is at from say 12 to 9, then 9 to 6. That is the muscle.
And you can see
on all the anterior side from 12 to 3 to 3 is mucosa. So now there are fibers which you can see between mucosa and muscle. Will inject water over there.
The glistening fibers over here, these are the submucosa. So here, this is where you need to inject.
So this is what we call as cotton candy appearance of the submucosal fibers. And whenever you are in doubt, inject water. That is what we do endoscopy also.
Are you near a G junction as per your formula?
Not yet. We are at around 39-40. Maybe another centimeter, because I think we are at the LES. We just need to cross it. Another 1 centimeter. This is my estimation. You can start seeing the palisading over there. See, just the beginning of the palisading. You see these dots?
These are all spindle fibers on the cardia.
Yeah, on the cardia. These particular vessels at the cardia make you wonder, that is the beginning of the thing. So the minute you go across this, that is the place where you will have crossed the LES. Now, maybe since you have held on with us for so long, we just show the LES.
This is a very difficult part. I think we should show this to audience, because this is one of the very difficult part. So the first difficult part is mucosal entry into the submucosal tunnel, and the second difficult part is to get through the G junction into the stomach. So you saw the first part, and this is the second part. So we are about to cross LES into the stomach.
This is the first time I have to probably advance my knife, because otherwise I am not reaching that.
So this is sometimes dangerous if you work away from your reach. Sometimes the bleed start and you are not able to reach it again. So
you can see a ring-like structure which could be in fact
the wrap also.
Crura wrap, yeah.
Yeah, in fact we can see a reasonably good wrap over there in this patient when we do a endoscopy. So this is just we've gone across.
Yeah.
We have gone beyond the G junction, it seems like that.
Almost, yes. My foot is stuck over there. I'm not actually able to advance it completely ahead. Little bit of oof.
need to dissect all
Yeah, there will be larger vessels now, isn't it?
There is a big vessel over there.
Yeah, maybe.
That vessel is a big. So
I can inject and then use a grasper and then probably we get. Maybe you want to go there, you can go there and come back. Okay, can you hear me?
Hello.
Hello.
Yeah, you're on. Hello. Now we are shifting to OT3 to Dr. Abe. So this is a 60-year female who presented to us with bleeding per rectum. She underwent hemorrhoidectomy 5 months ago for hemorrhoids. On colonoscopy, we found a lateral spreading adenoma just above the dentate line in the lower rectum. Biopsy turned out to be villous adenoma, and now plan is to do ESD. Over to Dr. Abe.
Yes, can you hear me? Yes,
So the region is laterally spreading tumor. It's nodular mixed type, and this is the anal verge located on the lower rectum. So the problem in this case is just very, very close to the anal verge here. So we have to approach and insert and dissect here at first, but because if we approach from here, the lesion gradually shifts to the anal verge, the following procedure must be much more difficult. So I'd like to start the procedure from here. Okay, so can I have the foot pedal? And what is the setting? Endoscopy I, effector 2, and interval 2, and okay, but here you see the edge of the distal side here. So
which knife you are using?
Dual knife J. Okay, this is a new device produced from Olympus. This knife includes radiologic function. Okay.
The lesion seems to be almost just inside the anal verge.
Yes.
So isn't it difficult to stabilize the scope there? The scope is almost out of.
Yeah, anyway, I have to stabilize the endoscope by myself. But any cap is very helpful to stabilize it.
Any risk if the hemorrhoids are present, any risk of bleed here once you are?
Yeah, so we have to take care of the bleeding.
Dr. Abe,
yes?
Is there any rule that you have to go from below upwards or above downwards in rectum or in stomach while doing an ESD?
My experience?
Yes, your experience.
Yes, so far I've experienced more than 500 cases of gastric ESD and 50 cases of colorectal ESD. Injection, please.
So no, you go from distal to proximal?
Yes, exactly. So now I injecting the hyaluronic acid using the dual knife J. Injecting. Okay, so now you see the recent submucosal layer. Okay, inject please. Oh, so this is a new advantage of the dual knife J. Okay, so I can extend the mucosal incision and submucosal dissection. Okay, so now we have to dissect here.
For a surgeon, the endoscopic surgery also could have been equally feasible because the lesion is very, very low. It's almost an anal canal lesion.
Yes, so the transanal resection is one of the great option. Okay, injection please.
Of course, the magnification in this scope appears to be much more than what we could get with a
actually
TANS or TANS.
Now I'm using the flexible endoscope H990, 190. So that this scope unfortunately doesn't have the orojet function. Sorry, magnification.
Would you retroflex to inject on the other side?
Yes, hopefully. But I already confirmed that I could do the retroflexion. But before that, anyways, we have to complete the mucosal incision and the submucosal dissection of this area. This is very important point of the ESD for the region very close to the anal bulge.
Are there hemorrhoids a contraindication for this?
No.
No.
Oh, I can do hemostasis. Needle out. Injection. Okay, then please someone hold on my scope.
Hold the scope.
Stop. Stop injection. Okay. Okay. Okay, please endoscope strip out. So the whole endoscope holding is very, very difficult. Well, anyway, I have to hold the endoscope and also ask someone else to hold the endoscope.
Yeah, Dr. Nachiket is helping you.
Okay, thank you very much. Hey, needle out, inject.
Because the lesion is low, the lumen is also finding it difficult to keep the lumen open.
Yes.
Isn't it? Yeah.
Okay. So line. Hyaluronic acid, please.
Do you use lignocaine in the injection?
Lidocaine, what is the lidocaine? I'm not sure.
Some local anesthetic agent.
Yes. No, this case, I can perform this procedure under the general anesthesia, so that I don't ask the technician to prepare the local painkiller.
Yeah, but if it is not general anesthesia.
Yes, no, it is necessary here, it's very,
We mix some local anesthetic agent along with saline adrenaline injection.
Yeah, exactly, yes. So, very, very nice point. Thank you so much. Okay, so anyways, I repeat this, I needed to complete this area. But after that, a remaining one should be very easy. Okay.
So you will take care of the lesion at the anal bulge, right? Go in, do a retroversion and start doing it from the up.
Right.
Okay, yeah, great.
外れてる。電極外れてる。
Will using some kind of an anal retractor and then doing this procedure would have made it a little more easier for the lower part?
This is one option. Injection, please. Okay, I'm now injecting. Stop.
હોસ્પિટલમાં કામ કરવાનું અમારું ઓપીડી બ્લોકમાં કામ કરવાનું અમને સેફ
Okay. So now I completed the distal edge. So now you see the recent submucosal layer color. It's a white, blue. Okay, so let's see. And this area, okay, injection please. Okay, stop. Okay, let me see the distal side. Okay, very nice.
Take it in and then inject. You can inject without that. Just you can inject just like that. It was large and you just take it.
And do you think there is some fibrosis there?
Maybe this is due to the vessel. Okay, so I need to check. Okay, please, someone hold with my scope, please.
I can see that you are using your cap to press on the bleeder.
Right.
And then get your coag forceps in place.
Yes,
Is that right?
Yes, right, exactly.
Very, very intelligent.
Yes, so actually I now use short type SD fluid. I actually bought from Japan. This is a short catheter SD fluid.
This is a short type of softwood, yeah.
Okay, coagulation, please. So please change mode to the soft coagulation.
Could you use the coag forceps also? Yeah.
Yes, exactly. It is quite difficult to hold the endoscope right now. And also the patient position should be long. So after this procedure, I asked the technician to change the position to sit-down position because okay, so please change the position. As you can see, the water and the blood always pull on the lesion. Due to the gravity, so we need to change the patient position. But before that, now let's change the patient position. Yes. Please turn the right. Supine. Okay, so very nice. Okay. So please hold the endoscope. Okay, so can I have your name, please? So now the submucosal layer is very exposed. So I'm going to dissect. What?
In colon, this changing of the position is sometimes very helpful.
Very, very helpful, yes.
Because you can get the assistance of gravity in such lesions and the fluid will not
yes,
stay.
So the gravity itself helped me a lot.
Yes.
Inject. Okay, now here you see now our injecting the solution using the Deenanath itself.
Yeah.
Okay, this is one of the advantage in Deenanath J. Okay. Okay.
Here you don't have to connect it to any pump. You can inject with the hand.
Yeah, now hopefully in the future, now we can do the injection near a water pump. But now we don't have any water pump assistant. Also the pretend to the assist collaboration is now the I'm the soft collaboration.
Yeah, we have done the force squared.
Okay.
Can we see what's happening in the other theatre for poem?
Yeah, we can just shift there. I'll ask them to shift there. Poem.
Yes, Samuel, I think we are back with you.
Okay.
So we had a little bit of difficulty at the G junction because there was quite a bit of, the muscle was quite adherent, and we just managed to get across over there. We were at the G junction kind of, just beyond it, and dissecting a little bit into the stomach. Oh, nice. That's maybe that is a medical aspect. Now we have to be very careful.
This is the important point which you have made. Once you are seeing a vessel on the mucosal side, and if you coagulate, it should be not that heavy coagulation that it cause a rent into the mucosa. So the vessel can be on muscle side and can be on mucosal side. You can liberally coagulate on muscular side, but while coagulating on mucosal side, you have to be very careful.
Yeah, you cannot cook a vessel on the mucosal side. You can cook it on the muscle side. Okay, very nice. Okay. Deenanath, please. Thank you. Yes. And predictably so, the muscle is quite a bit adherent to the mucosa at this level because of the the whole day I don't know. But in fact they dissected a little bit into the muscle before we realized that we are going a little bit into the muscle, and then we came up and found this plane.
Would it be even worse for a post-Botox case?
Yes.
Botox is the worst.
Botox is the worst because one, it causes severe chemical reaction, and second, you are injecting on 4 quadrants, so you don't have any other place to go. While in Hellers there is at least one
side which is
everything is fibrous.
Again, I think that we are getting into the muscle a little bit over here. You can see this plane. So the muscle is so densely adherent to the mucosa that it is not separating at all. Okay, step. Okay.
How many centimeters are you at in, according to your formula? Are you beyond 41?
41. I am at 41. No, you can say that rather than me.
Hovering around 40 and 41. So
I'd like to go to at least 42, I believe.
Yes.
42, 43, because see the G junction at the earliest, on endoscopy was 39. So 42 would be ideal, 3 centimeters beyond. Another
calculated G junction was at 41. So that means we have to go internal
43. 2 centimeters beyond that. Yes.
Can we begin with the lectures in about 5 minutes?
I think I can. And then what you can do is in between you can probably come in with some little bit of this.
Various stages you can just show your dissection.
Yeah, sure. I think the tunneling is over, and you all have seen a lot of tunneling today, so you all might be bored with it. Give me the name.
The manometry also maps the LES as far as this level of centimeters is concerned, isn't it?
Yeah.
Yeah. So what does the manometry level say about this particular patient as far as the MF is concerned? Yeah.
Manometry can't tell us the exact centimeter from where it is.
The range of level at least.
Okay. For grasp, please. And the please
Dr. Pujari is telling that the manometry is from nostril, so it has got different measurement as compared to endoscopy, which is per oral.
Dr. Mohan and Dr. Mohan, what are the tricks when at G-junction mucosa is adherent to the muscle? So what are the safety precautions do you take and how do you...
Take your time, inject as frequently as you want to do that, because the water injection is something which will open up your vein.
What I do is I avoid using cautery, especially when condition, when there is a mucosa which is tightly adherent to muscle. So if you use cautery, even endocut can cause mucosal injury. So at that time what I do is I fill the cannula with water and just try to mechanically dissect, probe, keep on probing and injecting without using current. So that will at least prevent the mucosal injury.
Yeah, and what Mohan is saying is very important, because what you can do is, you can probe the submucosa at 2-3 places, inject water, and then you start seeing strands going from the muscle to the mucosa, and then you can divide these strands. You can see over here, now these are the strands which you can safely divide. No. That is enough, no? No children. I think
Amol wants to do G poem also in this page.
No. Dr. Amol. Yeah?
Can we now start the lectures?
Yeah, sure. We are at 42-43, so this is enough. Meaning this is what, this is what I wanted to do.
You want to further
calculate this.
Before we sign off, could we see the endoscopic picture also from inside the
I just coagulate this for a moment and go out, because I don't want to enter again in here. Okay. Open. Close. Okay. You can see the small vessel on top.
That the mucosal side.
Yeah, so you have to be very careful. Close. Close. Okay.
So just a short burst will be enough here.
Okay. Open.
That's enough. So see that the vessel is blocked, but mucosa was not injured.
Hopefully, that will come to know when
he pulled out, that's the cord vessel was pulled away and then coagulated. Very nicely.
So we gone across.
Mucosal injury at all.
Okay.
And see that, very good.
Very nice.
See that? Fantastic.
Now we did not have to go out of the tunnel at any point in time. Now that is the proposed advantage of this formula, because you can calculate, you can safely go to 41 and add to something to that, then come out. So it avoids your going in and out in the tunnel and saves time. Injection.
Very nicely done, very happy congrats. I think the anatomy will follow as well as you've done so far. Thank you.
So we'll continue with the anatomy and thank you so much.
Amol, we are signing off now.
Yeah, sure.
And would we be beginning the lectures immediately?
Yeah, sure.
Okay, thank you.
Okay,
yeah.
Thank you. You go out and check. Okay, here we cast it.
We are now about to begin the last set of 3 lectures, and I would like to invite the chairpersons, Dr. Amit Maidev, Dr. S.P. Mishra,
okay,
Dr. V.G. Mohan Prasad,
okay, stop,
and Dr. Parimal Lavati.
Please.
I would like to invite Dr. Prasad Iyer for his talk on Barrett's esophagus, diagnosis and practice.
So good evening, everyone. It's a pleasure to be back again, and thank you again for the invite. You're very determined folks to actually sit so late at night after watching all the endoscopy and the lectures, so hopefully I'll manage to keep you awake. So Barrett's is a condition we see more in the Western world, and I'm just curious to see how many of you have seen or treated patients with Barrett's? Wow. Quite a few. Okay. That sort of seems to mirror what I read in the literature. There have been studies from India which looked at the prevalence of Barrett's in patients with reflux, and they seem to mirror what we see in the West. So maybe this is something that you can carry along with you. So I'm going to keep this talk at a very comprehensive level. Hopefully I'll finish in the next 15-20 minutes. So what do we mean by Barrett's esophagus? Just some basic facts. It is basically a metaplastic columnar transformation of the distal esophageal squamous epithelium and is thought to occur due to reflux-mediated chronic injury. So you can see in this cartoon that squamous epithelium undergoes injury and healing because of reflux, we think, which leads to metaplasia and then transformation to adenocarcinoma through low and high-grade dysplasia. That's the hypothesis anyway. Why is it important? I think the only reason it's important is that it is a precursor and strongest risk factor for esophageal adenocarcinoma, and it seems to increase risk by about 25 to 50-fold. And as I just alluded to, it progresses via dysplasia to adenocarcinoma. So the this figure basically shows you what Barrett's looks like on endoscopy. This is normal squamous epithelium, and this is columnar epithelium, which is a pinkish epithelium, and then it can give rise to adenocarcinoma, which will appear like this. Now, to diagnose Barrett's, we need to be clear about certain anatomic landmarks. The first of which is the Z line, which is a squamocolumnar junction, which is essentially the junction of the squamous mucosa to the columnar mucosa, and the GE junction, which we define as the top of the gastric folds. So in a normal individual, the squamocolumnar junction and the GE junction will coincide. In those who have Barrett's, the squamocolumnar junction is proximally displaced, and the distance between the Z line and the GE junction is called Barrett's. The third landmark is the diaphragmatic hiatus, which marks the bottom end of the hiatal hernia. So whenever you do an endoscopy on anyone with Barrett's, you mention three landmarks. The first is the squamocolumnar junction, the next is the GE junction, and the next is the diaphragmatic hiatus. So when do we define somebody as having Barrett's? So the diagnosis consists of two parts: an endoscopic component, which is defined by the presence of at least a centimeter or more of columnar mucosa in the distal esophagus, associated with, when you take biopsies from this area, the biopsies reveal intestinal metaplasia defined by the presence of goblet cells. And of course, you may have heard of the sort of arbitrary division of Barrett's into long segment, which is 3 centimeters or more, and short segment, which is less than 3 centimeters. So remember, you need two components to make a Barrett's diagnosis: an endoscopic component and a histologic component. You may have also heard of this term called the Prague classification, which is essentially something developed to make the reporting of Barrett's relatively common or relatively standardized throughout endoscopic reports. So it consists of two components: the M component, which is the maximal component, which is essentially the top of Barrett's to the G junction, and the C component, which is a circumferential component, which is only the part of Barrett's which is circumferential. So you can have a C2M2, you can have a C2M4, which basically means the total length of Barrett's is 4 centimeters and the circumferential segment is 2 centimeters. So why has the study of patients with Barrett's gained importance? It's essentially because of the escalating rise in the incidence of adenocarcinoma across the world, particularly in the Western world. So this is a graph which compares the incidence of esophageal adenocarcinoma to that of all other solid malignancies. And as you can see, the rate of rise over the last 3 decades has been exponential. In addition, the mortality from the disease continues to be rising as well. Indeed, when you look at the overall survival of patients with esophageal adenocarcinoma, at 5 years it is still a dismal 20% or less. Now, the only group which seems to be doing better is the group which is diagnosed with localized disease or T1 disease, where the 5-year survival appears to be better, about 50% or so. However, unfortunately, localized disease is only a fifth of all cancers. Most of the cancers diagnosed are at locally advanced or metastatic stages. Now, so coming to the management. So the management really depends on the following paradigm. We think that patients who have risk factors for Barrett's, and I'll come to this in a bit, and these include reflux, central obesity, smoking, and family history, will develop Barrett's, which will then progress through dysplasia to adenocarcinoma. We think we can prevent the progression of Barrett's to adenocarcinoma by first screening for the presence of Barrett's in those who have risk factors, followed by placing those with Barrett's in endoscopic surveillance, and when we detect either cancer or dysplasia, we apply endoscopic therapy and prevent the onset of cancer or treat cancer endoscopically. So that's sort of the summary of the management of those with Barrett's. What are some of the risk factors for those with Barrett's? The first is older age, more than 50, male gender, Caucasian ethnicity, reflux symptoms, and in those with reflux, the prevalence ranges from 2 to 20%. We use 10% as a rough landmark or a rough estimate. Central obesity, smoking, and family history. So this has given rise to several Barrett's prediction models. So this one from the University of Michigan, which was developed in men, allows you to plug in your age, your reflux symptoms, waist-hip ratio, which is a measure of central obesity, and your smoking history to give you a risk score for your risk of Barrett's. There have been other models developed. This is from Baylor, which includes not only this, but also circulating cytokines and adipokines like leptin. So what are the current recommendations for screening for Barrett's? It can be considered in men with chronic frequent reflux. Lost the screen. And at least 2 or more risk factors. And we've listed the risk factors here. At the moment, we do not recommend screening in women because we think the risk of developing esophageal cancer is exceptionally low. In addition to endoscopy, which is commonly used, transnasal endoscopy is an alternative. Now, before you perform screening, we recommend that the overall life expectancy of the patient should be considered. Now, transnasal endoscopy is something that is becoming more popular, and more recently, in addition to the regular thin lumen transnasal endoscopes, we have access to these endoscopes which are almost reusable without re-sterilization. So they come with these sheaths which can be then advanced over the endoscope and can be discarded after use, therefore eliminating the need for any reprocessing, allowing rapid turnaround and multiple procedures. So it's called the endosheath technology and can be done in the office, and you really don't need a reprocessor. So this is just a quick summary of a study that we conducted and published last year, where we compared the performance characteristics of transnasal endoscopy using this endosheath endoscope in a mobile van in the hospital, and compared that to that of sedated endoscopy. and we compared the participation rates and found that the participation rates were actually comparable in the groups which received transnasal endoscopy to that of sedated endoscopy. Indeed, we found that 8.5% of patients over the age of 50 had Barrett's, so it's a common disease, and we concluded that transnasal endoscopy was comparable to sedated endoscopy in terms of patient participation, yield of findings, safety, tolerability, and quality of imaging. Now, this is something that is an exciting advance in the field of screening. So in addition to endoscopy, we now can potentially screen for Barrett's using a simple, technologically basic device called sponge on a string. It basically consists of a capsule which encloses a sponge in a gelatin shell attached to a string. You swallow the sponge with the string, the gelatin shell will dissolve in the stomach, and then you pull out the sponge, providing cytology specimens of the entire esophagus. These can actually be analyzed for markers specific for Barrett's, allowing you to screen for the presence of Barrett's without endoscopy. This can be done by a nurse in a community health center. So the first paper came out in the British Medical Journal in 2010, where they looked at 500 patients, of whom 99% swallowed the capsule successfully with a sensitivity of about 74% and a specificity of 94%. More recently, a paper came out in PLOS Medicine where almost over 1,000 subjects were studied, 94% swallowed successfully, sensitivity for almost 80% with a specificity of 92%. So again, a technique which is very inexpensive, simple, can be applied in the community and may not require a physician to do. Let's move on to surveillance. So surveillance is really determined by what is your risk of progression to Barrett. So this is a risk for no dysplasia, low-grade dysplasia, and high-grade dysplasia. And as you can see, the risk progressively increases as your grade of dysplasia increases as well. So the first thing we do when we see patients with Barrett's is to put them on a PPI. It is not only just to control reflux, but also to reduce cancer risk. And this is a meta-analysis we published about 2 years ago, showing that when patients with Barrett's are put on a PPI, there is almost a 70% risk reduction in the risk of adenocarcinoma or high-grade dysplasia. What are surveillance recommendations? The recommendations are those with no dysplasia to follow them with surveillance every 3 to 5 years. In those with low-grade dysplasia, to either perform surveillance every 1 year or consider endoscopic therapy. How do you perform endoscopic therapy? It's essentially 4-quadrant biopsies in the area where the Barrett's exists, and every 1 centimeter in the presence of dysplasia, every 2 centimeters in the absence of dysplasia. If you see any visible lesions, biopsy them separately or EMR them and put them in their own bottle. The trouble with dysplasia and Barrett's is that it is very patchy, and oftentimes it will actually exist in a sea of no dysplasia or low-grade dysplasia. So when you perform surveillance endoscopy, only 5 to 8% of the surface area is sampled, which leads to missed dysplasia and cancer. So what we need to do is smarter and more efficient surveillance. So like we discussed today morning, you can either perform advanced endoscopy imaging like narrowband imaging, blue light imaging, FICE, eye scan, etc., where you can see more and biopsy less, perform more targeted biopsies and less random surveillance biopsies. You can increase the amount of Barrett's sampled by using brush techniques, or you can eliminate reliance on visualization and histology by looking for biomarkers. So again, just an example of advanced imaging. Again, we always perform high-resolution white light imaging. That is narrowband. This is blue light laser, and that's acetic acid. You can use techniques like confocal laser endomicroscopy, which provides you with real-time, live endomicroscopy images. These are images of patients who have no dysplasia. You can see the intact architecture. Or you can see high-grade dysplasia or cancer, where the cellular architecture is completely lost. And lastly, in those who have dysplasia, we recommend endoscopic therapy. What does this consist of? It consists of either resection or destruction of the metaplastic epithelium, controlling the acid reflux, which then leads to squamous reepithelialization. Endoscopic resection techniques include EMR and ESD, which provide tissue for histology, accurate staging, and potential for therapy. I'll talk about ablation techniques, and the most common ablation technique is radiofrequency ablation. So I think I presented this at the session today morning. Endoscopic resection consists of lesion identification, submucosal fluid injection to lift the lesion, and resection. You can either do this with a cap or with the ligation device, single resection or multiple resections. So EMR provides you with prognostic information. This is a patient who has T1A cancer with a risk of lymphadenopathy of less than 2%, making him a candidate for endoscopic therapy, protecting him from esophagectomy. However, when you see poor differentiation and lymphovascular invasion, the risk of metastatic lymphadenopathy increases to 10%, making you consider esophagectomy. On the other hand, if you see submucosal invasion, like you see here, the risk of metastatic lymphadenopathy is almost 25%, and you perhaps should consider surgery much more aggressively. Lastly, radiofrequency ablation. It is a thermal contact ablation device available in several configurations, including the circumferential and various focal configurations. It essentially induces thermal necrosis, and when you control acid reflux, the squamous epithelium grows over. So this is just a picture showing a Barrett's segment performing radiofrequency ablation, burning of the Barrett's mucosa, and over the course of a year, replacement of the Barrett's mucosa with squamous epithelium. And in this landmark trial published in the New England Journal of Medicine in 2009, we conclusively showed that when you perform radiofrequency ablation in a randomized study head-to-head with surveillance, you significantly reduce the risk of progression to cancer. And indeed, if you perform endoscopic therapy for T1A cancer, we have shown in studies published almost now 7 years ago that the overall survival in those treated endoscopically is similar to that of surgery. So in conclusion, chronic reflux and central obesity are independent risk factors for Barrett's and adenocarcinoma. Screening for Barrett's in those who have multiple risk factors by minimally invasive techniques can be considered. Recent developments may help make surveillance more accurate and efficient. Those with Barrett's without dysplasia should be surveyed every 3 to 5 years, in addition to a PPI being prescribed. And lastly, endoscopic therapy for BE-related dysplasia and T1A adenocarcinoma is standard of care. Thank you.
Thanks, Dr. Prasad, very comprehensive lecture. 2 questions I would start with. One is, there is a difference in the European and American guidelines on a diagnosis, and without histology it seems much simpler to diagnose. So is there any change in the natural history if you include histology and don't include? And second is, sometimes we find Barrett's as a bland Barrett's esophagus. Sometimes you find it with a lot of esophagitis. So you consider them as separate entities with separate natural history, or are they the same?
Yeah, so excellent questions. So the first question was related to whether we need intestinal metaplasia for the diagnosis of Barrett's. And, you know, people from the United Kingdom don't consider that essential, whereas we do. And I think there have been some pivotal studies, including those from Northern Ireland and including those, I believe, from Holland, which have conclusively shown that the risk of progression to adenocarcinoma, the elevated risk in progression, is really confined to those who have demonstrated intestinal metaplasia. So I think that issue is more or less settled. Now, the British will argue that if you keep biopsying these patients, you will find intestinal metaplasia at some time. But in the era of increasing medical costs and us trying to be more cost efficient, I think we should try and focus on the subgroup which has the highest risk of adenocarcinoma. Now, your second question was esophagitis with or without Barrett's. I really don't know if we need to consider them as two different etiology or two different categories. The important thing would be to heal the esophagitis with PPIs, because some pathologists might actually call inflamed Barrett's as dysplasia. So we want to avoid that. GI pathologists seem to be able to distinguish between inflammation-related atypia and true dysplasia. But I think before you take biopsies, it's better to heal the esophagitis with PPIs.
That was a brilliant lecture. Actually, one comment is, like many endoscopists label this as Barrett's esophagus on endoscopy. I think that is a misnomer. People have to use the terminology as columnar lined esophagus until we get the histopathology, because as for the reason that you showed, even though the British argue that it's enough to show that there is a columnar lining to call it Barrett's. The second question is, like, even in cases when we use the 190 series endoscope and we do a zoom and we do an NBI, we do targeted biopsy, where we think the pit pattern is different from that of the cardiac type of pit pattern. There's a slightly elongated or whirly type of pit pattern, but still the biopsy comes negative for goblet cells or Paneth cells. So what do you do in such cases? Do you have to do a surveillance on these guys or not?
So that's an excellent question. So last year in the Red Journal, the American Journal of Gastroenterology, this question was addressed. And what they found was that in those with no interstitial metaplasia, you find interstitial metaplasia about 20% of the times. So the recommendation now is to look once more, perform adequate number of biopsies, and if it's still negative, you discharge them from surveillance.
Okay. The last question. Yes.
A Barrett's esophagus with a hiatus hernia, would that form an indication for surgery, or will still the patient need to have Barrett's hiatus plus reflux esophagitis? And in case if we do the Nissen's fundoplication, will the surveillance pattern still be the same?
Yeah, I think that's an excellent question. So it has been now, I think, fairly conclusively proven that anti-reflux surgery of any kind will not reduce the risk of cancer more than medical treatment. That being said, most of our patients with Barrett's will have large hiatal hernias, and they tend to have the worst kind of reflux. So the indications for reflux in someone with, indications for surgery for someone with Barrett's are the same as the indication for surgery in someone without. If you can't control the reflux medically, you subject them to surgery. However, the surveillance regimens don't really change because they can still progress to cancer.
Thank you. I think a very brief question from the back.
What's your principle on follow-up of short segment Barrett's in surveillance?
I'm sorry, I didn't understand. I didn't get the last word.
No, there's often people say that if it's a short segment Barrett's, you don't really need to survey. Is that true, or what do you do with short segment Barrett's?
Yeah, excellent question. I think the more important thing is to make sure that the patient truly has Barrett's, in the sense that you don't want to biopsy an irregular Z-line and call that short segment Barrett's. True short segment Barrett's between 1 and 2 centimeters seems to have a lower risk of progression to adenocarcinoma for sure. But at this point, we are not recommending that you stop surveillance. You could make an argument that maybe those with long would get surveillance every 3 years, short every 5 years. But we are not recommending at this point in time that you stop surveillance.
And that was a great lecture, Prasad sir. And again, to say that in South, we're looking at our 7-year data, there is no increase in the adenocarcinoma among all the cancers of esophagus. Our data shows between 10 and 30% is adenocarcinoma. It has stayed as such. There is no increase, progressive increase, at least in Coimbatore. I wouldn't know about the other parts of the country.
Sure. I think it'd be interesting to see what's happening in India.
Thank you so much.
Thank you.
Thank you, Dr. Prasad. I would now like to invite Dr. Moin Khashab for the last talk of the day, Acalasia Cardia, Current Trends in Management, 2016.
Okay, good evening. I don't think I've ever given a lecture at 8 p.m., but that shows
that you guys are eager to learn, so that's good. You've seen a couple of POEM procedures today, and now it's time to shed light on the literature and some data. I'll be showing very few videos that I showed in the morning, but a lot of you were not there, so I'll show them. I'll start with a case presentation, and actually this was my first POEM patient that I did 4 years ago. He was a 25-year-old gentleman with dysphagia, chest pain, weight loss, failed empiric dilation, and you can see here the, oops, we don't have slides. Okay. So 25-year-old, this is the typical esophagram with the Barrett's peak appearance, and endoscopy showing pooling of saliva and a tight lower esophageal sphincter. It's important in these patients to rule out eosinophilic esophagitis, so you get proximal and distal biopsies, and that was ruled out. Formally, we score the patient's symptoms using the Eckert score that takes into consideration 4 symptoms: weight loss, dysphagia, chest pain, and regurgitation. And this patient had severe symptoms with a total score of 8. So just a little bit of a background on treatment of achalasia. We know that smooth muscle relaxants like nitrates and calcium channel blockers, for the most part, they are ineffective, and they also have a significant side effect profile. And even if a few patients respond, continued treatment is essential. What about Botox? Jay Kasrisha, who works with us now, him and Tony Kalu actually published the first paper on Botox for achalasia in 1996 in New England Journal of Medicine with some initial good results. But if you look at the literature, at more than 12 months, only 40% of patients have sustained response. Typically what we see is good initial response, but as you know, Botox is a foreign protein from pigs. So repeated injections create antibodies to Botox, and that's why they become ineffective in the long run. And as you also heard during the day, that Botox causes submucosal fibrosis. So in these patients who subsequently want to have definitive therapy, whether it's surgical myotomy or endoscopic myotomy, procedure becomes more difficult. So in 2016, unless the patient is not a surgical candidate or a candidate for POEM, Botox should not be used. What about balloon dilation and Heller myotomy? Also, some of you were questioning if that patient post-Heller should have gotten a balloon dilation rather than Heller. If you look at this randomized trial, again published in the New England Journal of Medicine, it's a randomized multi-center trial. It found that balloon dilation was equivalent to laparoscopic Heller myotomy. However, there was a 4% perforation rate, and importantly, up to 4 endoscopies with dilation was allowed in a period of 2 years without considering this as treatment failure. So it was a little bit weird in terms of definition of treatment failure and treatment success. But our experience has been that balloon dilation does cause or result in treatment success, but it's very often short-lived, and recurrence of symptoms is very frequent. Heller myotomy, it's very effective. However, it's surgery, it's invasive, and if you don't do a fundoplication, there is a severe reflux, so fundoplication is a must, and that causes actually a long recovery period after surgery with temporary dysphagia. Background on POEM. The group at the Mayo Clinic came up with submucosal endoscopy and submucosal tunneling in 2007. Jay Pasrisha, who I just mentioned, performed swine experiments of endoscopic myotomy. So the story is that Jay and Professor Inouye were at a meeting in 2008 in Australia, and Jay mentioned the idea to Inouye, and Professor Inouye started doing the procedure right away. We know how of a skilled endoscopist he is. So he did champion translating this procedure into clinical care, and also he coined the term POEM. This is his first publication in 2010 on 17 patients with excellent results, as you can see. Simple equipment, so one knife. I use one knife, as you saw today, for the entire procedure. I don't think there's need for more than one knife for cost reasons. Distal attachment cap and a generator. That's all you need for POEM. So this is a cartoon that will show after a submucosal bleb incision using an ESD knife. It's just small incision to introduce the scope. Tunneling, so important to do esophageal tunneling, involves the LES area and also cardia in the cardia. Very essential to do adequate cardiomyotomy, as I mentioned earlier. There's some surgical data that shows how important that is. So we expose the muscle. Next will be the inner circular myotomy that involves the lower esophagus, the lower esophageal sphincter, and the cardiomyotomy. This should be at least 2 centimeters. Usually we go 2 to 3. Once you do that, that results in opening of the lower esophageal sphincter. So step 1, as I showed, is mucosal entry. So we do a bleb, and it's a 1.5 centimeter longitudinal incision. Some people do horizontal incision. They're more difficult to close, so I think it makes sense to do a longitudinal incision. In patients with chest pain, suspected spastic esophageal disorder, that incision has to be high in the esophagus to subsequently create a long myotomy. And some of you saw some of these videos, but just to reiterate the procedure, submucosal cushion followed by incision using the needle knife or the triangular tip knife. We want to get into the submucosa, and we can see here the submucosa. Once we get that, then we move the scope towards the LES to avoid pressure on the muscle and causing myotomy. And myotomy here is a big issue because we shouldn't touch the muscle here. This area here will serve as a flap closure method to aid in avoidance of a leakage. Now we're in the tunnel. So we want to form the tunnel in the same method as we do endoscopic submucosal dissection. The tunnel again is started not at the incision, it starts at the incision and it goes 2 to 3 centimeter distal to the GE junction, and we use the triangular tip knife, and as I showed you, I use a spray coagulation mode. You can use an endocut Q mode, but I think spray coagulation is efficient. So again, let me show you this. And so we always put the muscle at 12 o'clock, mucosa will be facing it, and we work at this plane here near the muscle to avoid injuring the mucosa, which is extremely essential. And you can see here spray coagulation. All of us do APC, and we're very familiar with this technique. It's a non-touch technique. There's nothing wrong if you touch it, but it's more efficient just to do it this way, and it's pretty efficient procedure. So next will be the endoscopic myotomy, and as I showed you, I do selective inner circular myotomy. Again, it's all semantics. Eventually, it's effectively, it's a full thickness myotomy. But just targeting these inner circular fibers, you stay away from the vital mediastinal structures. Again, I do the myotomy using spray coagulation mode, but you can use it. You can do it using endocut Q mode. And the last step will be the closure. And this is the endoscopic myotomy video, and I'll show you again how to create it. So usually a couple of sprays to have enough room to hook this is the beauty of the triangular tip of this TT knife. You can hook muscle fibers easily. So we want to continue to just cut inner circular fibers like a skinning, this area, going deeply until we reach that plane, and we can see here some longitudinal fibers, until we see this plane between the inner circular and outer longitudinal. And this becomes really a fast process, and you can get to that plane pretty fast. And when you identify it, you just go towards the LES, cut the LES, and then the cardiomyotomy. And this is the closure. I'll skip the video on the closure. Use just so on. So, some studies I want to show you. So most patients do respond. If you look at the literature, most patients do respond. The beauty of the procedure, look at this, the Eckert score, 10 to 1.3, 7.1 to 1.1, 8.8, 1.4, 0, 0, 1, 1.1. So not only we're seeing significant response, patients who respond significantly with either no or very mild residual symptoms. So the significant clinical improvement is seen in the majority of patients. Our patients just stay overnight in the hospital, and they get discharged the next day. CO2 is a must. If you don't use CO, if you don't have CO2, you cannot do the procedure. It's a must. If you have visible capnoperitoneum, especially causing symptoms, low tidal volumes, then we can just put a varus needle or an angiocath and drain it like we drain ascites. Very simple. Acid reflux. So abnormal esophageal acid exposure, I tell my patients at least 1 in 2 will need a proton pump inhibitor. Having said that, the minority of these patients will be symptomatic. So it's not about just symptoms, it's also about abnormal acid exposure. So let's talk about some studies that compared surgical myotomy to POEM. There are a few small studies. This is one study that showed basically everything was equivalent except for a shorter procedure duration, but in terms of safety, everything, major and minor complications were equivalent, and even the length of stay was equivalent. Second study from Chicago also compared laparoscopic hilar myotomy to POEM, and also showed that both were equally effective in decreasing the Eckert score, 6 for POEM and hilar myotomy. 6.4 Eckert score to 0.7, 5.4 to 1. But as expected, what's the benefit of POEM? Is that these patients have less pain after the procedure, so the visual analog scale was significantly less. That resulted in less pain medications. There is a faster return to activities of daily living. Just endoscopy versus surgery, that's expected. This is the best study that compared hilar to POEM from Lee Swanstrom out of Oregon. So Lee is a super thoracic surgeon. He's done tons of hilar myotomies, and then he started doing POEM. And this study, he included his initial POEM procedures. So the difference was that POEM was faster. Also, the length of hospital stay was shorter with POEM. And also, long-term relief of dysphagia was 100% in POEM, 71% in the hilar myotomy group. So the hilar myotomy group had more solid food dysphagia. I think that's attributable to the fundoplication rather than a failed procedure. The fundoplication takes some time to relax, and the patients usually will have a certain degree of dysphagia up to 6 months after the procedure. Post-operatively, 39% of POEM and 32% of hilar myotomy patients had abnormal acid exposure. So importantly here, we say a patient got a hilar myotomy and got anterior or posterior fundoplication. That's not a guarantee that the patient doesn't have reflux. So we don't go and get a pH study in these patients. That does not mean they don't have abnormal acid exposure. You can see here, even with a partial fundoplication, a third of patients will have reflux. So this is Dr. Swanstrom conclusion. The data reported here directly compare hilar and POEM and show similar rates of technical complications and, in fact, possibly better outcomes for the POEM procedure. So these are the comparative study. We published this last study in Endoscopy International, and it is for only type 3 patients. So I think POEM is, theoretically, superior to Heller in these type 3 patients because they need a longer myotomy. So it was a total of 75 patients, and 49 underwent POEM, so all type 3, 26 underwent laparoscopic Heller myotomy. The procedure was faster, of course, with POEM, but at the end we want response. Response was 98% with POEM, 80% with laparoscopic Heller myotomy. And why is that? We think it's because of this. The median length of myotomy in the POEM group was 16. Again, it's very easy for us. We can go as high as we need in the esophagus. For laparoscopic Heller myotomy, although it's feasible to go high to the esophagus, it requires a very skilled surgeon, and it's not consistently possible. But typically the surgeons do 6+2 myotomy, and I think this longer myotomy translates into a better outcomes. So here are the potential advantages of POEM over Heller: less invasive, shorter procedure time, shorter hospital stay, less pain, eliminates wound complications, and eliminates the need for anti-reflux procedures and its issues. It has a clear advantage in type 3 achalasia patients. I think the major advantage of Heller over POEM is the non-long-term outcomes. That's a major issue with the POEM literature. It's all short-term outcomes, and we really don't have good information about the durability of the procedure. And I think also we're seeing more and more literature on reflux after POEM, and we're going to see more data soon. You saw Amol doing a POEM after Heller. We're going to present data at DDW showing that there is decreased response in this population because these patients have declared themselves as a more difficult to treat patients, but small studies that have shown effective procedure between 92 and 100% of patients. We published our data on the initial 60 patients, and you can see here that the clinical response was 92.3%, and our patients just stay really an overnight stay in the hospital. Here you can see the length of myotomy is 11.7, but our results are similar to published results with efficacy in about 90% of patients. You can see normalization of the IRP, and most patients, 75%, who attained clinical response had either no or minimal residual symptoms after POEM. We do see mild and moderate adverse events. We don't see severe adverse events. There has been some interest, some questions of POEM for spastic esophageal disorders. So type 3, Acalasia, jackhammer, and diffuse esophageal spasm. We published this last year in GIE, and you can see that diffuse esophageal spasm and spastic achalasia, they respond very well. By the way, these are all patients refractory to medical therapy. It doesn't make sense to do POEM in a patient you've not given a calcium channel blocker. If they respond 100% to calcium or to a pill twice a day, of course you're going to try that first. But in patients who respond, we don't have a lot of effective medications. And POEM, I think, is a good idea. Jackhammer is a difficult entity to treat. Even with these aggressive POEM with long myotomy, we only see response in 70% of patients. So a final couple of slides. Our patient underwent POEM, and he did very well. He added 20 pounds in 1 month. His Eckert score continues to be 0 for the 4 years later. And again, this is just one patient. We do need durability data. I think I'll stop here, and I'm happy to answer any questions. Thank you.
Hi Mohan, great talk. So if one were to take this issue of reflux after a Heller myotomy and a POEM one step further, and a lot of the myotomies and the Heller myotomies are being done with fundoplication, whether it's DOR or something like that. The argument I have heard about a lower risk of reflux after POEM is that you are not doing any external dissection, and your, the muscle layer, the angle of His and things like that sling fibers are still intact. Do you think there's any truth to that?
Yeah.
Or are you seeing as much reflux, symptomatic or not symptomatic, after POEM as one sees after halemyotomy?
Yeah. So I mean, this is the $1 million question, and initially the theoretical answer was that, yeah, POEM, we don't destroy the diaphragm, the ligamentous attachments to the diaphragm, the angle of Hess, so we're not going to see a reflux. I think it's theory, you know. I mean, you saw the POEM I did today. That GE junction is wide open. You know, I mean, I'll be surprised if this patient does not reflux. The good news, the difference with Heller is that it's not just the rate, the severity. And I think this is where the difference is. The severity is, it's mild reflux. Out of 150 patients I followed for reflux, I've seen, I told you this, 3 severe symptoms. 3 only out of 150. So I think we see abnormal acid exposure in 50% of patients, and maybe more. That's, I think, a conservative number. But if you look at the literature, it will be 50%, the minority of whom are symptomatic. And I tell my patients, if you have abnormal acid exposure, whether you're symptomatic or not, you're going to be on a PPI.
Yeah. My comment regarding this is, if you see the studies with Heller's myotomy, those who do Heller's myotomy with hiatal dissection, and those groups where Heller's myotomy was done without hiatal dissection, the patient who had Heller's myotomy with hiatal dissection and then underwent fundoplication was equal to the reflux associated with lap Heller's myotomy without hiatal dissection. So if you do not do hiatal dissection, then the reflux rate is much lesser, and they may not require fundoplication. And in fact, those patients are equal to POEM. So that means if you do a Heller's myotomy with limited hiatal dissection, are equal to POEM, and they do not require fundoplication.
I think for want of time, should we allow another couple of 2 quick comments? Yes.
Without hiatal dissection, does it allow the enough length of the myotomy? Because unless you do the hiatal dissection, you can't go into the posterior mediastinum to complete it. But with the adequate length of it allows.
Yeah, I think so. I'm not sure how surgery can be consistently. You know, you need to get to the mediastinal esophagus. You know, you're gonna do a hiatal dissection, but we have to stop underestimating the rate of reflux after POEM. We did meta-analysis. The rate of reflux in Asia was significant. So this is going to be presented at UEGW. Dr. Ripici and I did this together, and the rate of reflux in Asia post-POEM is less than in the West. If that's a function of BMI, we don't know, because there's no BMI data in the literature. But in the West, it's at least 50%. That's a fact.
Would you, just a last comment, would you then routinely put people after POEM on a PPI?
So what I do, my practice is I put them on a PPI, and 4 to 6 months after POEM, I take them off PPI for 1 week. I do a formal pH study, and I tell them, if you're negative, you stop. You continue you don't go back on it, and if it's positive, I advise you to stay on it to avoid long-term complications of abnormal acid exposure.
Okay. I think that is a wonderful lecture, and you showed very well, just with one instrument, just the triangular tip knife, you can do the whole procedure so beautifully.
Yes.
So that's a good news for many of them who are aspirants of starting the procedure. My question is, like, if they want to start the POEM in their own units, like how should they get trained? I'm sure this animal model is just like a sampler. So
if you so on PubMed, we just published a paper exactly that, how to train and how to start a program, and this is how we did it. So the first thing is reading the literature very well, not just knowing the response rate. You have to go to the methods section and dissect the literature, see tons of videos, see experts do the procedure. Then you go to the animal lab. You can do procedures on explants first. And when you're consistent, you're doing well, you go and do experiments on live pigs. And when you're consistently able to do it without killing the pigs, then you're good. Then it's time to do clinical procedures with a proctor. So have an expert there to help you with the first couple of procedures, and choose easy cases. Patients who are treatment naive, non-sigmoid esophagus, young patients without many comorbidities. Choose your patients wisely initially, and the learning curve, I think after 15, 20, you can start moving to more difficult cases. Importantly, also, you should be able to manage complications of POEM, whether the bleeding, perforations. You have to use large clips, stitching, stenting, be able to handle severe bleeding. So I think these also techniques are very important to be able to have positive outcomes.
Okay. Thank you so much once again, and we have the live demonstration. I think Anil is waiting there in the hospital.
Going back to the operating rooms for about 5 minutes.
Yeah. So just Saichura's here to finish the ESD. He's done a wonderful dissection. So we just wanted to show you the last bit of it before we conclude for the day. So you can see that he's done a wonderful dissection. Saichura, maybe you can even retroflex and show them what. Okay. Yeah. Or maybe you can divide this and then you show them the entire.
Yeah, I completely dissect and cut anal bulge and with advanced endoscopy to the lower rectum. Actually, I couldn't show you, but a very, very severe fibrosis was seen. I didn't know the reason, but just makes sense. Amor told me this patient actually underwent a hemorrhoidectomy with an anal bulge. So the crazy one, but very, very severe fibrosis was seen. So I really appreciate you can appreciate if I have to dissect
You can see at 12 o'clock, yeah. Okay. At 12 o'clock there was dense fibrosis. What you see over there, we cut almost, even injection was not remaining there. So maybe you can just remove the final specimen and then probably we'll close the day.
The final, yes. But here you see the edge of the exposed submucosal layer. I'm going to show you the basic technique of IP-knife nano.
Anil?
Yeah.
There's some residual polyp, no? So you're just going to do APC or?
He's left that piece because he wanted to show it to you all, how to use the IP-knife nano and
Can you keep your mic closer to your mouth?
Yeah. So that's just a little bit of the polyp which is remaining now, and more is going to divide that and. Sorry.
Okay. Here you see the exposed edge of the submucosal layer, and then the curvature of the muscular layer is now the 2 to 8 upper position.
Yeah.
I took the edge of the exposed submucosa and then into the IP-knife parallel to the muscular layer. Unfortunately, this is a lower rectum, so I have to worry about the perforation.
You can see that it is remaining very close to the muscle layer, but protecting the muscle layer in any case. That's the last bit now.
Anil, do you use this IT knife?
No, this is the IT nano, which is for colorectal, and we use this sometimes. Yeah, I usually prefer the dual knife, but there are situations where you have to use the IT knife. So sometimes you need a combination of knives to get the desired result. So for the colorectal, IT nano and dual are the preferred choices.
Yeah, but it's very so hard.
It's very hard. So it's not even cutting so well with the IT knife. Here you need a sharper knife sometimes. So with the IT knife you have to pull and cut. Now in this kind of a situation, sometimes it gets difficult to cut with a 90 and you even use a hook sometimes or a dual.
Now quarterly it doesn't work right now, so please check. Otherwise, can I have the dual knife?
Probably the dual knife will cut away. So can you see the muscle layer on the right hand side and the mucosa on the left? And the submucosa are beautifully separated out using the cap.
Yeah, of course, very, very clear.
Very clear.
That's why the soft caps are so useful in introspection.
Okay, so now I would like to make sure the orientation of the submucosal layer. So this is a dual knife gel. Now we can inject the solution directly. Okay, inject.
Amul, how long this procedure has gone on?
About 1 hour.
It's gone on for about more than an hour and a half.
I still recall you doing one of those colonic resections in Coimbatore. In our hospital. We all left for food and then you were continuing to dissect.
I think that's probably something when you start thinking.
I think surgeon requires a lot of stability and stamina and consistency in doing this procedure. I think it has to be slow and time consuming. And people don't list any other case, I think, when they post these cases, ESDs and all that.
Yeah, sometimes it gets very difficult. And, they're also unpredictable. They're not like ERCP.
I'm a little closer. Your mic is far away from you.
Yeah. There are, all third-phase endoscopy procedures are not, they're also unpredictable procedures. Sometimes, a lesion which looks simple can get difficult, and something which looks difficult can sometimes become, you can finish in a short while. But they are unpredictable at times, and so budgeting time in a workshop for these procedures also is always a challenge.
So that is a lateral spreading tumor which you dissected at Coimbatore. That was a fantastic job you did, but it required a lot of time.
Okay.
Okay, so just the final bit, I think, over there.
Yeah, I hope so. This area is still there.
This area is still there.
It's right in it, please. Because of the injection would be better. So injection.
Okay, so because there is fibrosis, in this situation sometimes you need the sharp sclerotherapy needle to inject. Because
Amal, what is your distance from the anal verge for this lesion?
The lesion starts at the anal verge. You saw it starts just at the dentate line and then go inside for about 7 centimeters.
I can please.
It's on one wall. There's another very a complete circumferential lesion which we did NBI on, and if Sechera is still up to it after today's case, actually we plan to do that tomorrow, so let's see. I don't want to talk to him about that just now. Don't want him to, get stressed.
Amul, when you are using this cautery current very close to the dentate line, what are the chances of the patient developing a thermal injury and pain?
They do get a little bit of irritation, anal irritation, but which is easily manageable with, which is similar to after hemorrhectomy or fissure surgery. So, manageable with local anesthetic gels and things like that. So, we would give them local gel application once they get out of anesthesia, and they have to continue it for about 3 or 4 days.
Okay, so let's change the patient position to prone.
Supine. So he's now changing the position to supine. So with that, because changing the patient position is very important. Otherwise, what happens is Until then, we'll just clean. I'm sure it's been a very long day so far. So until we're changing the position, I would also like to thank all the moderators, chairpersons, and especially the MOCs over there who have done a wonderful, job of moderation, and all the faculty for their patience and for demonstrating all the procedures so well. All the delegates and the participants over there for being so patient and so enthusiastic about this workshop, because otherwise there's no fun in it.
I think Amol, more important is we should all be thankful to Dr. Amol Bapi for doing this wonderful workshop. Can I have a big round of applause to Amol and his team here who have done a phenomenal job in not only hands-on training, also lectures and beautiful demonstrations. So Amol, thank you so much. Thanks. Congrats once again.
No, but more than that, the team over here, I'll be introducing all of them formally tomorrow morning before we start the live cases. But big applause, round of applause for the anesthesia team over here. Dr. Sunil Bapa, Dr. Hamita, and everyone, and especially the Sechero. It's nearly 8:30, and he did develop a little bit of sweat when there was so much fibrosis, but he's still going great times with this procedure. And that's the tenacity. You need the tenacity of a Japanese person to be able to do ESD. Probably if there's one single factor which is important when you want to start doing ESD, probably it is that. That is what I will say. Rest of all the other things you can probably learn with experience and practice. But the tenacity of a Japanese is something that is, probably inherent to these guys. So a big round of applause for Saichiro. Thank you very much. You see that the minute the patient was turned to supine, the plane opened up better.
Amol?
Yeah.
Amol, would you like to take up that question from the floor? What is first space endoscopy? What is second space and what is the third space?
See,
you want to clarify?
Everybody is clear about first space and third space. First space is obviously luminal endoscopy. Third space is what we are doing in the submucosal. Second space, some people say that it is the peritoneal cavity, and some say the cholangiopancreatoscopy, where it goes beyond, into the pancreatic and biliary tract, which is not truly in the lumen, but it's on the sides. So, I don't know, actually, Dr. Hamid is also there, I believe. He also can comment on that.
Any comments from the floor? Because we have all learned people here. Which is second space, which is, first space is regular luminal endoscopy. What about the second space? Would you call it notes or would you call it notes? Notes is second space?
Okay, so that's the last tag.
So this is related to gastroenterologists.
Okay, Dr. Vijayan, so this is the last tag which is being divided now.
Amit wants to give a comment and Rajesh.
Okay, thank you very much.
Okay.
Amit?
No way.
Okay.
You want to say something? No. Oh, second space, Amit says it's bile and pancreatic ductoscopy.
Yeah, that's what some people say, and some people say...
Notes is fourth space. Notes is fourth space, peritoneoscopy.
Yeah, these are ducts. I wouldn't call them space. but people who call that third space is related to gastroenterologists. First we discovered the lumen, then notes discovered the peritoneal space, and then third came the third space or submucosal endoscopy as a byproduct of notes.
And in fact, yes.
What I think is lumen, ducts attached to the lumen, intralumen and outside lumen. That's how four spaces. Lumen is first, ducts attached to lumen is second, intramural is third, and outside lumen is fourth.
I mean, this is, there is no hard and fast rule. This is the way we have called it.
I think we should publish this, because there should be a consensus in what is the fourth space.
And Dr. S.P. Mishra's class, I think it will close from here. We'll just deliver the specimen and we'll confirm the hemostasis and then close from here. So I think we'll go off screen now, and I'm sure everybody has had a very tiring day and a very long day. So let's now relax with some drinks and dinner and some fellowship. We'll join you very soon, hopefully. So leave some food for us. I think Sajida will be very hungry.
Yeah, we'll reserve some food for you. Yeah, thank you. Yeah, bye-bye.
Bye-bye. Okay, see you soon there. Okay.
With this, we come to the end of today's session. Please join us for cocktails and dinner.
So just one announcement. I think we've not been able to take all the lectures today. So tomorrow, please announce that we will start at 8:30 instead of 9. So that by 8:30, everybody, if they can be there, then we can finish and we can take more cases.
Okay.
Okay.
So tomorrow's sessions will start at 8:30 in the morning, so that we can cover the remaining lectures.
We can take this, definitely.
Yeah, the same hall. Thank you very much, and please join us for cocktails and dinner.
Yeah. Okay. Right, so.
Gotcha.